Sir, ready?
Yes, I think we are good to go.
Okay,
Yeah.
sir.
So
So please start in three,
can we
two,
have the main slide, please, on the right out?
one. Please start. So we are live.
So good evening, everyone. It's a great pleasure and honor to welcome you all for this Clinical Oncology Updates 2026. We carry the greetings from the Pink City, Jaipur, and it's a great pleasure to welcome the young, dynamic Dr. Pulkit Nag with us, who's the convener for this Clinical Oncology Updates 2026. He's a consultant medical oncologist at Apex Hospital, Jaipur. With this, we give the floor to Dr. Pulkit. Dr. Pulkit, over to you for starting the session, please. Once again, very warm welcome and good evening to everyone. So, Dr. Pulkit, over to you.
Thank you, Tarunji, for the wonderful introduction, and good evening to everyone. So it gives me immense joy and pleasure and a lot of pride to start this meeting on a great positive note. And I'm really humbled that the guide under which I did my residency, I have a privilege to call him to start my first ever virtual conference. I have only attended under him. I have only attended and received the guidance with all my consultants. And there is no pleasure and joy to invite Dr. Ajay Bapna sir, who is currently working as Director and Head of the Department of Medical Oncology at Bhagwan Mahavir Cancer Hospital. Sir, thank you so much for sparing little time for me and showering your blessings on me. Over to you, sir, for the introductory part. Thank you, sir.
Yeah. Good evening to all of you, and thank you, Dr. Pulkit Nag, for giving me the opportunity to be the opening batsman for this important meeting. So, why I'm calling this important meeting? Because when I was going through the scientific program, I found that you have included most of the burning issues, and I think it will be a good academic feast for all the oncologists. And I can already see the enthusiasm amongst the delegates who are part of this meeting, as more than 25 people have already joined this meeting. This is really a very big thing that in webinar people come and join this program, and I think all will be benefited by your clinical oncology update 2026.
That is a significant
Keep
turn.
keep
Managing
organizing keep organizing these kinds of meeting, because the science is changing so fast that we need to really abreast our knowledge with the what is latest happening in the field of uh, clinical oncology, medical oncology, and hemato-oncology. So I wish you all the best for the success of this academic meeting, and over to you. Thank you very much.
Thank you. Thank you so much, sir. Thank you so much, sir, for starting this meeting on such a positive note.
Thank
Thank
you.
you, sir. Thank you. Thank you. Thank you, sir. Tarunji, do we have Dr. Sandeep Jasuja, sir, joined?
Sir, you can start your discussion. Yeah, you can invite the chairpersons. Dr. D'Souza will be joining in a minute. So we
Okay.
already have
Okay.
Dr. Lalit Sharma, sir. So please go
Sure,
ahead, sir.
sure. So, as seen in the agenda, we are going to discuss and start first with the breast cancer session. And for that, I'm going to invite my first chairpersons. The first is Dr. Lalit Mohan Sharma, sir, under which guidance also have did and studied a lot. And sir, thank you for always keeping the mood so lighter and happier. And welcome to you, sir, as a chairperson in the conference. And over to you, sir. Over to you.
So thank you so much, Dr. Pulkit and Bhapna sir, for the excellent opportunity, and truly appreciate that the youngsters are coming up in a big way. Dr. Tara, Dr. Pulkit, everyone is like inclined to do more and more of academic activity. So truly appreciate that fact. And it's good that we are meeting on a Zoom platform or a digital platform, because that like clears many boundaries, timelines, and other things also. So
Thank you.
thank you so much. So we'll be starting the first session. Dr. Tarunji, can I have the first slide?
Yeah.
Dr. Tarachan, I think, will be the first speaker for today's session.
Yes.
So all of you know Dr. Tarachan very well, that he's young, dynamic, senior consultant medical oncology at Bhagwan Mahavir Cancer Hospital in Jaipur. And Dr. Tara is like already not budding, but already grown up medical oncologist in the whole fraternity. With this small word, over to you, Dr. Tarasan, for your talk, and he'll be covering about the breast cancer and this particular session given on the screen. Over to you.
थैंक यू वेरी मच सर एंड मेरे को लगता है आज दिन आपके साथ ही है मेरा एंड मॉर्निंग टू इवनिंग सो सच ए नाइस डे फॉर मी ना सो now I'm going to discuss this important trial now. This is a trial is the LEDERA trial where the oral SERT, that is giredestrant versus the standard of care in as endocrine therapy in adjuvant treatment for patients with hormone receptor positive early breast cancer. This was the phase 3 trial. So as we already know that the ER positive HER2 negative breast cancer is around more than 70% of early breast cancer. And usually the endocrine therapies are the mainstay of treatment. So the last approval for the pure endocrine therapy was in the around 2000 era. That was a ATTACK trial and Big 198. And then that around 3-4 years back, there was a trial that Monarch E that came as a game changer where the CDK4/6 inhibitors were introduced in high-risk patients in early breast cancer. So so-called early breast cancer is a curative intent, but still their patients usually develop recurrence within 5 years of endocrine therapy. The number is around 25 to 30%. So many patients stop early treatment due to the reason including the safety, tolerability, and risk of recurrence. So just to understand what is the giredestrant, it is a potent next generation oral SERT that and full estrogen receptor antagonist that is designed to drive the deep and sustained inhibition of ER signaling, both ligand-driven and ligand-independent. In going to the cellular visibility assay, giredestrant has been shown to be more potent than other SERDs. If we go with the Coopera breast trial and Empress trial, giredestrant has shown the benefit in neoadjuvant setting also and over the conventional anastrozole and tamoxifen. While the LIDAR breast cancer tested whether the giredestrant is superior to our current endocrine therapy as an adjuvant therapy in hormone receptor positive, HER2 negative early breast cancer. So going to the schema of this breast cancer patient, this trial, patients were randomized with the ER positive, HER2 negative early breast cancer having the disease of stage 1, 2, and 3, where the patient and the pre or post-menopausal both were taken and breast cancer surgery within 12 months to be considered this as an adjuvant, and neoadjuvant chemotherapy, if indicated, were also taken. So patients were randomized 1-to-1 with the giredestrant versus the standard of care. Giredestrant was a 30 milligram daily and long-term follow-up was taken. So patients were stratified according to the medium versus high-risk stage 1 to 3 breast cancer. Medium were patients with the N0 disease and having the high-risk feature, while the high-risk patients were the pathological T4, N2, N3, or if there was N1, then other high-risk features were there, including the tumor size more than 5 centimeters. So region-wise, also patients were stratified and previous chemotherapy, menopausal status, primary endpoint-wise IDFS, and key secondary endpoints DFS, DRFI, or IDFS. So to statistically design, the primary endpoint was IDFS, that was defined as the time from the randomization to the first occurrence of one of the following: either ipsilateral invasive breast cancer tumor recurrence, ipsilateral locoregional invasive breast cancer recurrence, distant recurrence, contralateral invasive breast cancer, or death from any cause. The primary efficacy analysis was performed in the intention to treat population and analyzed by the treatment group. This IDFS was analyzed using the log rank test, utilizing the stratification factors, risk, previous chemotherapy, and menopausal status. The study was considered positive if the IDFS analysis was statistically significant, where the p-value was taken significant if it is p less than 0.0217. The pre-specified efficacy interim analysis of IDFS occurred when 336 IDFS events were observed. Approximately 77% of events for the final IDFS analysis. The clinical cutoff date was August 8, 2025. The first interim OS analysis occurred after the efficacy interim IDFS analysis. was statistically significant, and assigned protocol therapy and follow-up will continue until the final OS analysis. This was the patient flow consort diagram. The demographic patients were having age around 54 in both arms, and yes, female patients were there. And in this population, Asian patients were also in significant number, around 22% in the both arms. And Asia region-wise, if we go Asia Pacific, it is around still 26%. Menopausal status wise, it is 40-60 ratio, premenopausal 40% and postmenopausal around 60% in both arms. Even the ER low positive were also taken around 1 to 10% of the cells. Those were 2.2 versus 2.5% in the control arm, and rest were the strong positive. Stage wise, if we see that the most of the patients were belonging to the stage 2 and stage 3, as is or nodal status was also mainly around N1 node positive, around 77% patients were node positive. Risk category, high risk patients were around 70% in both arms, and medium risk patients were the 30% in the both arms. So previous chemotherapy were taken in around 20% in the both arms, while it was not taken, previous chemotherapy was taken around in 80% of patients in the both arms. So primary endpoint of the IDFS, events occur 140 versus 196 with the hazard ratio of 0.70, 30% of the reduction in the invasive disease recurrence or death. If we see these graphs, then we can see that with the time, the graph becoming more separate and wider. The gap is more wider with the time. IDFS in key subgroups, we can see that all the subgroups analysis showed the benefit in the experimental arm. And the distant recurrence free interval also, there was a events were 102 in the experimental arm, while the 145 events were occur in standard of care with a hazard ratio of 0.69. Again, we can see here the distant recurrence free survival, the graphs becoming more and more separate with the time. Interim overall survival, it is around 57 event versus standard of care 71. So stratified hazard ratio was 0.79. Here, after a long time, again we can see the overall survival graphs are overlapping around at the 4 years of the study. So be cautious before choosing the drug and wait for the long-term results also. For the safety purpose, median treatment duration around 31 months in the both arm. Median dose intensity was maintained in the 99% of the patients. Adverse events, all grades occurred in 95% in the both arms. And adverse events with fatal outcome around 0.3 in the guided strand, while it is 0.8 in a standard of care arm. So we see all the events that adverse events, treatment-related adverse events, grade 3, 4 adverse event, and serious adverse events were comparable between the treatment arms. And going the overview of the safety profile, the arthralgia and the hot flushes were bothering the patients, as we can see in the routine practice also with the hormonal therapies. So since approval of aromatase inhibitors in 2000, later of breast cancer is the first trial to demonstrate the benefit with a novel endocrine therapy in early breast cancer. With a median follow-up of 32.3 months, the LIDERA trial demonstrated a statistically significant and clinically meaningful improvement with upfront guidance over standard of care endocrine therapy in ER-positive, HER2-negative stage 1, 2, 3 early breast cancer. IDFS ratio 0.70, 3-year IDFS rate 92.4 versus 89.6%. Overall survival trended in favor of guided arm. Although if we see those graphs, then we have to wait for the long-term follow-up, as the graphs are overlapping around at the 4 years of the timed horizon. So DRFI was improved versus the standard of care endocrine therapy with a 31% reduction in risk of developing distant metastasis disease. So the safety profile was favorable and consistent with the known profile. The discontinuation rate was lower with the guided strength compared with the standard of care. Overall, the results support guided strength as a potential new standard for patients with hormone receptor positive, HER2 negative early breast cancer. So thank you. And if any question, I will be happy to answer if there is any question.
Thank you,
So
Taran
much,
sir.
Dr. Tarachan. Thank you so much for excellent overview, and opening batsman has done a great beginning of the activity and event. And I think questions we can keep little later, because already we are running little late behind the schedule. So without much delay, may I invite the second speaker?
सर एक चीज बोलो सर।
Sir,
Yes, yes.
सर वो जो आपका बैकग्राउंड इस तरह से कि आपके बाल जो कम मतलब ज्यादा मतलब है ना वो ऊपर दिखा रहा है, वो हवा वो चलती है ना मतलब ना, वो मतलब ऐसे लगता है ईद का चांद, मतलब सॉरी मतलब वो थोड़ा सा बाल।
अभी वो ईद का दूध का चांद बाद में करेंगे. First,
sir,
let us go
we
to
have
this.
Dr. Jasuja sir also, sir.
Yeah, Dr. Jasuja, welcome. Dr. Sandeep, can you unmute, please? So can we go with the second talk for today?
Yes, sir. Yes, sir. Please, sir.
Second is, I think, Dr. Rishabh Jain.
Yes, sir.
Yes.
Can you, team, can you display Dr. Rishabh's talk? So in fact, Dr. Rishabh is senior consultant medical oncologist at Renova Rajasthan Hospital in Jaipur. He will be talking about neoadjuvant therapy in HER2 positive early breast cancer. So over to you, Dr. Rishabh.
Thank you, Lalit sir. So I will be presenting my talk on redefining neoadjuvant therapy in high-risk HER2 positive early breast cancer, which is basically Destiny Breast 11 phase 3 trial, which compared TDXT THP against an anthracycline-based standard of care. So first of all, what is the need of this regimen? So current standard do achieve a decent pathological CR, as we know, around 39 to 64%. But anthracyclines has two major side effects. First being a long-term cardiotoxicity, another one being the risk of secondary leukemias which are associated with anthracyclines. So hence the Destiny Breast 11 trial was designed. It was a phase 3 trial. The target population was HER2 positive early breast cancer, which were high risk being more than equal to CT3 or a node positive disease. It had three arms: the TDXD alone arm, a TDXD THP arm, and a dose dense AC THP arm. And the primary endpoint was taken as the PATH-CR. Coming to the population which was there in the trial, it was a notably high-risk patient population, with nodal involvement being in 90% patients, a clinical tumor stage of T3 or T4 in 43.8% patients, stage 3 or more disease being in 50% patients, and 72% patients for hormone receptor status positive. As we know, traditionally, the hormone receptor positive patients have a lower PATH-CR. And when we look at the results, the difference in PATH-CR was 11.2%, with TDXT THP arm having a 67.3% PATH-CR. Also, when we compare the subgroup analysis, when we compare the hormone receptor positive subgroup and the negative subgroup, we see the positive subgroup had 9.1% of the difference, pathological CR difference, which drives most of the population, as the population 80% were hormone receptor positive, where the hormone receptor negative had a PATH-CR of 16.1%. Now, when we look at the RCB, the residual cancer burden, there was still a marked difference, 81.3% in the TDXT THP arm, while 69.1% in the dose dense AC THP arm. And as presented yesterday in ESMO Breast 26, the results for this RCB was presented, which shows an 81.3% response rate in TDXT THP arm, while 69.1% in dose dense AC THP arm. And the subgroup analysis also showed a marked difference of around 13 to 18%. So when they took three arms, the first arm was TDXD alone arm, but it did not succeed and had to be closed early because of a lower PATH-CR rate. And it was found out and concluded that TDXT alone is insufficient to beat a 5-agent polychemotherapy comparator in this neoadjuvant setting, and we require TDXT THP, the full therapy, to the patient. Coming to the actual endpoints which we care about, PATH-CR is a surrogate endpoint, sure, but EFS benefit, the hazard ratio benefit is there around 0.56, but the data is yet immature. Also, when we look at the systemic tolerability of both the drugs, we find the anthracycline containing regimen, the standard of care, had more grade 3 or more adverse events, more serious adverse events, and more adverse events leading to dose interruptions. And same goes for the hematological toxicities, because dose-dense ACTHP had more neutropenia, more leukopenia, and more anemia. And hence TDXT THP do appear to be a safer option to give. But let's come to the concluding points which we have, like the cardiotoxicity is the main concern with dose-dense ACTHP arm. And ILD traditionally has been known to be the most severe adverse effect, the one which leads to scratching our heads in TDXT patients. But in this subgroup of patients, the ILD was only 4.4%, which is considerably low when we look to other trials, which is around 8 to 10%. So concluding, the TDXT THP arm gives a better tumor eradication, a more systemic tolerability, and a better long-term safety. And also, when we look at it, the neoadjuvant phase, the PET-CR is a well-established surrogate for survival, and critically demonstrate how much patient post-surgical burden would be there. And hence, TDXT THP appears to be a better design. So, concluding my talk, neoadjuvant TDXT THP represents the first major breakthrough in over a decade, establishing a highly effective anthracycline-free pathway for high-risk HER2-positive breast cancer with an unprecedented efficacy and a redefined safety measures. Thank you.
So thank you so much, Rishabh, for excellent input and very good slide set as well. In fact, there are a lot of learning things from your talk. In addition to science, the good PET-CR, the slides are also extremely good. So thank you so much, and I think we keep discussing towards the end so that we don't delay the whole program. So next is Dr. Lalit Sharma.
Sir, we have Dr. Jasuja sir also now attend as a faculty, sir.
Yeah,
Good evening, good
yeah.
evening, everyone, and thank you very much for giving the opportunity, Dr. Pulkit Nag, for being here
Thank you, sir.
with all stalwarts. And really, I'm sorry because of there was some technical glitch, so could not able to join that meeting at the time. So moving forward, we have Dr. Lalit Sharma with us, consultant medical oncologist, Manipal Hospital, Jaipur, and he will be delivering the talk on ASCENT-3, a randomized phase 3 study of Sacatumumab Govindin versus chemotherapy in patients with previously untreated metastatic triple-negative breast cancer who are unable to receive PD-L1 inhibitor. Dr. Lalit, over to you.
Thank you, sir. Thank you so much. At the outset, let me thank Dr. Pulkit for organizing such a wonderful event and giving me the opportunity to be a part of this. So
Thank
the
you, sir.
job cut out for me is to discuss the results of the ASCENT-03 trial. So at the outset, my declaration of interest is that the slide set has been provided by the organizers. The all credit goes to patients, investigators, and the institutes who participated in the trial. So about metastatic triple negative breast cancer, it is one disease wherein we have been clutching for straws for long. There are two main reasons for this. One is that there are not many options. Two is even the PD-L1 inhibitors, which have come as a big way in this particular disorder, even for that, majority of our patients are not eligible for either clinical reasons or logistic reasons. This problem is further compounded by the fact that around more than 50% of the patients who are treated in the first line do not receive a second line treatment either due to clinical deterioration or demise. And even with the available molecules at this point in time, the median PFS is very dismal. It is less than 6 months with chemo and even with the current standard of care. So, to basically conclude,
Dr. Lalit, sir, sorry to interrupt. Your slides are not moving. Are you sharing the slides or we are sharing? Daud, are we sharing the slides?
I'm already sharing my screen. I believe I'm on the third slide.
No. This is only the first slide. Second, yeah. Next slide, sir.
How about now?
Yeah. Now you're on slide number 3.
Yeah.
Great. Okay.
Okay. So, this basically makes the rationale for ASCENT-03 That one is that there is a huge vacuum in this particular disorder, wherein we are looking for newer molecules who have better efficacy. As far as sacituzumab govitecan is considered, SG has itself kind of established itself in the second line setting, and it is the only TROP2 directed EDC which has shown a survival benefit in the multiple phase 3 metastatic breast carcinoma studies, and it is approved for the second line setting in the TNBC setting also, and the pre-treated hormone positive HER2 negative metastatic breast carcinoma. So this particular trial was designed to address this particular patient population, especially the TNBC. It was a phase 3 trial, multicentric, and the enrollment criteria was patients who had either advanced inoperable or metastatic TNBC and who were not candidates for PDL1 inhibitors, either because of negativity, which was defined as CPS score less than 10, or if patients who had CPS more than 10 and were previously treated with PDL1 inhibitors in the curative setting, or if they were eligible due to a comorbidity such as immuno-oncological disorders. Moreover, if the patient should have been more than 6 months since the treatment in the curative setting, and the previously treated stable CNS metastases were allowed in this particular trial. Patients were randomized in a 1:1 ratio to the experimental arm receiving SG in a 10 milligram per kg day 1, day 8, 21 days fashion, vis-a-vis the observational arm receiving chemotherapy of physician choice, which was either taxanes in the form of paclitaxel or nab-paclitaxel or gemcitabine and carboplatin. The primary endpoint of the study was PFS, and the secondary endpoint was overall survival, overall response rate, duration of response, and time to response. Safety parameters were also analyzed, and quality of life were also analyzed. Eligible patients were offered crossover also. So patients in the chemotherapy arm who once progressed were eligible for crossing over to the SG arm. So as far as the statistical analysis goes, around 540 eligible patients were enrolled, and to control for overall type 1 error, hierarchical testing procedures was also implemented. As far as the demographics go, both the arms were pretty well matched, both for be it for age, be it for the ethnicity or the geographic region to which patients belonged, ECOG performance status, and whether there was any curative treatment-free interval, be it de novo or recurrence after 6 to 12 months or more than 12 months. PDL1 status, majority of them were negative, 99%, and the patients were pretty well matched in both the arms for the metastatic sites, be it lung, liver, or brain. Around 5% of the patients had brain metastasis in this particular study, which were either well treated or stable. And the exposure to chemotherapeutic arm, whether taxanes or gemcitabine, was also equal. At the presentation of the results, SG showed a significant improvement in the PFS to the tunes of 9.7 months versus 6.9 months in the chemotherapy arm, with a hazard ratio of 0.62. And the 6 months PFS rate was also better in the SG arm, 65% versus 53, and the 12 months PFS rate was also better in the SG arm. The magnitude was more even at 12 months, 41% versus 24. So SG did demonstrate a statistically significant and clinically meaningful improvement in the PFS versus the chemotherapy, with a 38% reduction in the risk of the disease progression or death. Even with investigator assessment, the PFS advantage was maintained, 9.6 months versus 6.8, with a hazard ratio of 0.64. The advantage was seen across all predefined subgroups, be it for the performance status, be it for the age or the disease status at the baseline. The tumor response, though, was more or less similar in both the arms. It was around 48% in the SG arm versus 46% in the overall response, objective response rate in the chemotherapy arm. though the duration of response was far better in the SG arm, that is 12.2 months versus 7.2 months in the chemotherapy arm. The overall survival data was not mature at the time of presentation of these particular data, which was presented in ESMO 2025. So as far as the safety summary goes, this particular advantage came at some cost, with grade 3 or 4 events being slightly more in the SG arm, and there were 5 deaths also documented in this particular study. But at that point in time, in the study, prophylactic use of GCSF was not kind of standard of care or the part of the treatment protocol. So probably that part could be taken care of with now well-established GCSF protocols. The most common
Sorry
side
to
event
interrupt
in
you,
both
sir.
the arms were neutropenia. Yeah,
Sir, sorry to interrupt you. Please conclude your session
it's just
in
one more
one
slide.
minute.
Thank you.
Sir, please.
So, as far as this safety summary goes, the most common adverse event was neutropenia, and the most common grade 3 or more adverse event was also neutropenia. So, there were no new safety signals. So, to conclude, SG did show a statistically significant PFS advantage, a statistically significant PFS2 advantage also, and the safety profile was also kind of similar to the previous studies, and there were new safety signals. So as per Ascent 03, SG as a potential new standard of care for patients with previously treated metastatic TNBC who are not candidates of PD-L1 inhibitor. Thank you for a patient hearing. Over to the organizers.
Thank you, Dr. Lalit. Very nice and elaborative talk you have given, and I think now we should move in the for the further session because of the time constraint. And any question can be asked in the chat box. And for next session is sponsored by AstraZeneca, and our next speaker is Dr. Abhishek Sharma, consultant medical oncologist, Goyal Hospital and SKG Cancer Center, Jodhpur, and he will be talking on evolving trend in the HER2 MBC. Dr. Abhishek, over to you, please.
Sir, I think Dr. Abhishek is stuck somewhere. So, can we, if you and Dr. Lalit Mohan Sharma sir allow, can we move on to the next speaker, sir?
Sure, Dr. Prabhat Rajan will please. Is a consultant medical oncologist and Fortis Greater Noida, and this session is sponsored by the Zydus, and he will be talking on the role of neuroma in the NSCLC innovation to impact. Dr. Prabhat Rajan, over to
Good,
you.
good evening, everyone. I am Dr. Prabhat Ranjan. First of all, I would like to thank Dr. Pulkit for giving me this opportunity. And today I'll be speaking about role of nivolumab mainly in NSCLCs. So this session is sponsored by Zydus. So I'll be talking, as we all might have started to use in our practice, Tishtha, which is there, which is Indian biosimilar. Let me share my screen first. Is it visible? Excuse me, can somebody tell me if my screen is visible?
Yes, sir, visible.
Visible.
Yes,
Okay,
sir.
so I'll start. So basically, I'll be talking about role of nivolumab in NSCLC from innovation to impact. As we know, it is sponsored by Zydus. The product, which is the Indian biosimilar, is Tishtha. We have it available in 40 mg as well as in 100 mg. Initially, the permission was taken in 2015, and after going through all of this gamut, finally it is launched in January 2026. And from January 2026 we have started to use this, and we are seeing results also. So basically, what is Tishtha? It is a biosimilar nivolumab which contains the same active drug substance like the innovator, and it is a human monoclonal antibody of IgG4 kappa isotype composed of 1308 amino acids with molecular weight of 143 kilodaltons approximately, and expressed in genetically engineered Chinese hamster ovary cells, just like the reference product, and developed with the same pharmaceutical composition as the innovator. So approved strengths are 40 mg as well as 100 mg. So we can give either 140 or 240. Even if we want to give 360, that is possible, just like the original molecule. So as we know that there is a very good role of immunotherapy in non-small cell lung cancers. So I'll be talking about role of nivolumab. It is approved in neoadjuvant setting, definitely, and the tumors having PDL1 expression of one or more than one, definitely we can use nivolumab in combination with platinum doublet chemotherapy. Then there is approval in combination with ipilimumab also, and without ipilimumab also, nivo can be used in metastatic non-small cell lung cancers. Monotherapy is also there. So basically, we prefer in lung cancers, we want to give neoadjuvant because it can prime the immune system more effectively prior to surgical resection, leveraging the presence of abundant tumor neoantigens. So of course, when the tumor is already there, it can be prime, the neoantigens are there, and we assume that the response will be better. And also in adjuvant schedule also it can be given, which boosts the immune tumor control following surgery induced immunosuppression. So international guidelines recommend the use of neoadjuvant chemoimmunotherapy for eligible patients with resectable NSCLC who are planned for surgical resection. So what it does, the IO activates the immune system to elicit a broad systemic anti-cancer response, which is driven by exposure to neoantigens widely present on primary tumor. It also targets micromets and prevents the metastatic spread, and also it provides the earliest treatment opportunity to improve the
I think Dr. Prabhat Ranjan sir ka disconnect हो
Network
गया.
slow hai. I think you can
हाँ.
call him once again.
yes. Hello.
Yes, sir.
Yeah, is it audible? Somebody said something that it got
Yeah,
disconnected.
sir. Yeah, I think we lost you in between because there might be some issue, network issue
Issue.
at your
Okay,
end.
okay. Right now, am I audible and visible?
No, sir, visible, audible, but your screen is
Slide
not
is
visible. You
Slide
need to
now.
present.
Now is it available? Visible? No.
No, sir. Kindly share again.
Okay, okay. Let me see.
Welcome, Dr. Sumani, sir. Welcome, sir.
Evening. Thank you.
Thank you, sir. Thank you, sir.
So can we share it from our end?
I'm just sharing. If it is not visible, then
Yeah,
you
it's
guys share
coming.
it.
It's coming, sir. It's coming.
Coming, no?
Yes, sir. Just make it
Is
full
it
screen.
visible?
It is visible. Make it full screen.
Yeah, sure. So as I was talking about Checkmate 816, which is the neoadjuvant trial, key endpoints was pathological complete response and event-free survival. So eligibility criteria, the most important is they should not have any EGFR or ALK rearrangements, and the resectable cancers were taken in this trial. Baseline characteristics were more or less similar. So when we look at the pathological complete response when nivolumab was given along with chemotherapy. The PCR rates was as high as 24%, whereas it was only 2.2% in the chemo alone arm. If when we see a stage wise, there is definite more benefit in patients who received nivolumab, which is obvious also. So the coming to the EFS definitely also at 3 years, 4 years, there is clear-cut benefit in favor of nivolumab arm. Median EFS was 43.8 months in the Nivo arm, whereas it was only 18.4 months in the chemotherapy only arm. So clearly there is a favorable trend in overall survival also. So 5-year OS data we have, and median overall survival has not been reached also, whereas it was 73.7 months in the chemo alone arm. So 5-year OS rate was 65% for the combination, whereas it was only 55% with the chemotherapy arm. So long-term benefit also is there, and it did not depend on the surgical approach. Whatever the surgery, the type of surgery was done, in all the subsets, there was a benefit with addition of nivolumab. This is a subgroup analysis which showed which showed in patients in whom there was ctDNA clearance. In those patients, definitely PCR rates were higher, which also we would expect. And if you look at the safety summary, there are no grade 3 or 4 events which were increased because of addition of nivolumab. So it is safe to administer also. So this was, I was talking about Checkmate 816, which only gives 3 cycles of nivolumab along with chemotherapy in the neoadjuvant setting. Then there we have Checkmate 770, which is also a phase 3 trial. In this also, there were resectable stage 2A to 3B cancers, and definitely no EGFR or ALK mutations. In these patients, we gave actually in these patients, it was given nivolumab was given perioperatively. Initially, for 4 cycles, it was given 360 mg 3 weekly along with chemotherapy. And then after surgery, nivolumab was continued at 480 mg 4 weekly for a year, and the primary endpoint was EFS. So if we look at this, the surgical outcomes, definitely there was a benefit with the addition of nivolumab, perioperative nivolumab. Coming to median EFS, with addition of nivolumab, the median EFS did not reach. That means more than 50% of the patient did not have any event, whereas in only CT arm, it was 18.4 months. Hazard ratio also, it is 0.58. So the probability of occurring was reduced by 42%. If you look at stage wise also, there is clear cut benefit in the favor of nivolumab arm. This is also even in patients in which PDL1 was less than 1%, there was clear cut benefit in the favor of nivolumab arm. And yes, obviously the magnitude of benefit was more when the PDL1 score was higher. So looking at the PCR rates, here also the difference between the arms with the addition of nivolumab, it is about 20%. In Checkmate 816 also, there was 22% benefit. The more PCR rates were seen with the addition of nivolumab. And when we look at the major pathological response also, it is 35% versus 12%, and the difference is 23%. So definitely there is a greater response with addition of nivolumab. So talking about the conclusions of this study, neoadjuvant nivo plus chemo followed by surgery and adjuvant nivo was associated with a significant clinically meaningful improvement in EFS versus neoadjuvant chemo plus placebo in patients with resectable NSCLC. I already discussed about the PCR and the MPR rates. EFS benefit with perioperative nivolumab was observed in all those patients, in patients with PCR after neoadjuvant, in patients eligible for adjuvant regardless of PCR status, and in patients who were unable to receive adjuvant therapy also. And there was no...
Sorry to interrupt you, sir.
Yes.
Sir, please conclude your session in next 1 minute.
The last study, which is Checkmate 9LA, in this Nivo EP was given nivolumab along with ipilimumab, and there was more benefit in PDL1 less than 1%. So clearly in those patients in which PDL1 is less than 1%, we can probably give this protocol of checkmate 9LA, in which nivolumab along with ipilimumab was given. There was more benefit with this protocol. As we can see here, in less than 1%, more than 1%, benefit is definitely there in overall response rates, median duration of rates, and PFS as well. So as we can see here, overall survival rate, also 6-year overall survival rate was 16% versus 10%. So this is metastatic setting. So that is why. So the conclusion was durable long-term survival advantage, long-lasting responses, sustained PFS benefit, consistent benefit across all the subgroups, barring it could be squamous, non-squamous, PDL1 less than 1% and more than 1%, and no side effect was increased with addition of immunotherapy. So this is what I hope we can use more and more immunotherapy, and with the Zydus launching Tishtha, it is clearly more affordable for our patients, and we have already started using it, and it is showing good responses. So thank you so much. Thank you.
Thank you, Dr. Prabhat, for the wonderful talk. And I would request Dr. Lalit Mohan Sharma sir or Dr. Sandeep Jasuja sir to please invite for the next session, sir. Dr. Lalit Mohan Sharma sir, are you there, sir?
So,
Yes,
Dr.
Jasuja sir,
Sandeep
please, sir.
D'Souza sir is there.
Yeah, yes,
Dr.
sir, please,
Sandeep
sir.
D'Souza sir is there.
So, very excellent and nice elaborate talk, Dr. Prabhat. And I think Dr. Abhishek is there right now, or still he's not able to join us?
Sir, we are going to go with the panel discussion first, and then after that, we're going to have Dr. Abhishek Sharma's talk, sir.
Okay, so for next session, that is sponsored by Roche, and that is on moderation and advancing immunotherapy in lung cancer, Tecentric monotherapy, and the innovation of subcutaneous delivery with Tecentric subcutaneously. And our moderator is Dr. Ankit Agarwal, a consultant medical oncologist, Gitanjali Hospital, Udaipur. And to assist this panel, we have Dr. Jitendra Kumar Pahaljani, consultant medical oncologist, SCG Cancer Center, Jaipur. Dr. Abhishek Sharma, consultant medical oncologist, Goyal Hospital and SKG Cancer Center, Jodhpur. Dr. Preeti Agarwal, consultant medical oncologist, Narayana Multi-Specialty Hospital, Sanganer, Jaipur. And Dr. Narayan Adhikari, consultant medical oncologist and hemato-oncologist, AIMS, Udaipur. Uh, Dr. Ankit Agarwal, over to you for your session.
Thank you, sir. Thank you for the introduction.
I have one query that the Dr. Narayan Adhikari, it seems to be it should be at Jodhpur. I don't think AIMS is in Udaipur.
Sir, he's in Udaipur, sir. Dr. Narayan is in Udaipur, sir.
But AIMS Udaipur.
So this is actually American International Institute of Medical Sciences, is also abbreviated as AIMS. It's not AIMS, wala AIMS, but yeah.
Okay. Go ahead, Dr. Ankit.
Thank you, sir.
Welcome,
Thank you,
Dr. Ankit.
Hi, Pulkit bhai. Thank you. Thank you for calling, and thank you for inviting us.
Thank
Okay,
you.
so
Thank you.
without wasting further time,
Sure.
we have all our panelists online, right, with us. Okay, so in the next 20 to 25 minutes, what we are going to discuss is we have discussed this previously. We have discussed. Okay, so we have discussed about immunotherapies and lung cancer. I think lung cancer was one of the most earliest malignancies wherein immunotherapy use was started, and we'll just go through the immunotherapy part again. And we'll also take into the opinions of our expert panelists about their experience of using immunotherapy in lung cancer and their experience of using Tecentric monotherapy. We'll also discuss about the recent launch of Tecentric in the subcutaneous form, and we'll discuss with our panelists as to how do they feel about the recent introduction of Tecentriq and how will this change the administration of immunotherapy for our patients of lung cancer. Okay, so moving on, this is a Roche sponsored session. These are the disclaimer. This is the agenda for the next 20-25 minutes. We'll discuss about the role of Tecentriq monotherapy in metastatic non-small cell lung cancer. We'll discuss about the subcutaneous form of Tecentriq. We'll also discuss, if time permits, I think we can also move on to discuss about the role of Tecentriq monotherapy in the adjuvant setting of non-small cell lung cancer. Now, basically, we know that we'll start with Dr. Jitendra. Dr. Jitendra, are you with us? Has Dr. Jitendra joined? Dr. Pulkit?
Yes, sir, he's in the session.
All right. So I think immunotherapy has transformed the management of first-line metastatic non-small cell lung cancer to a huge extent. We all know. So basically, Dr. Jitendra, this question is for you. What are your points to take into consideration when you tell a patient that the patient requires immunotherapy? What guides your therapy selection? Do we have Dr. Jitendra? Okay, we can ask Dr. Abhishek. Dr. Abhishek, are you with us? Is it? Am I audible?
Yes, sir, you are audible. I request all the panelists to switch on your videos.
Okay, so Dr. Preeti, can we have Dr. Preeti?
Yes, I'm here.
Hi. Okay, so what are the points to discuss when you talk about immunotherapy for your patient? What are the guiding points that help you to decide what treatment your patient should receive?
So, what is the diagnosis of the patient, particularly small cell, non-small cell? Then, in non-small cell, whether there is a targetable mutation present or not. Then, third is what is the PDL1 status? What is the disease burden the patient is having, and what is the pocket? What pocket the patient is having? Everything guides the treatment of deciding what type of immunotherapy this patient is going to receive.
I think pocket comes into picture. I think for most of us, the pocket comes into picture as the major concern. And when we talk about the best of treatment, will for the rest of our discussion, we'll discuss about what is the best available treatment for a patient, excluding the financial cost and taking into consideration the other more important factors. I think histology and as you said, the actionable biomarkers, they are very important in deciding what all treatment plan do we have, what is the whole treatment plan for our patients. Dr. Narayan, so the treatment options with metastatic non-small cell lung cancer who do not have any kind of actionable driver alteration, what are the things that come to your mind? Do we have Dr. Narayan? Oh, yes.
Yeah, sir. So there are multiple choices now, like previous times. So my first choice is generally chemo plus immunotherapy. So I also keep into consideration the PD-L1 expression, and if it is above 1%, then I always tend to go with chemo plus immunotherapy. And for those patients who are more than 50% of the PD-L1 expression, then there is also the option of single agent immunotherapy. If their performance status is not that good and they are not fit for chemotherapy, then in that case, I generally prefer single agent immunotherapy. But most of the cases, when tumor burden is high, patients yes is good, then I tend to go with single immuno plus combination chemotherapy regimen for the respective type of either adeno or squamous lung cancer, sir.
Okay, so Dr. Jitendra, has he joined? Can we ask?
Yes.
Okay, so Dr. Jitendra, is it right to say that every patient of non-small cell lung cancer should receive immunotherapy, irrespective of the PD-L1 status?
If driver mutation negative, then definitely there is a role of immunotherapy, whatever depends on the status of the PD-L1, what chemotherapy you want to do. But definitely patient should be given benefit of eye.
And then what do you feel that what is the role of PD-L1 in current scenario of managing? Why do you get a PD-L1 then if you know that immunotherapy is to be given for everyone?
Since the beginning, we have PDL1, and everybody says it's not a best marker, it is a dynamic marker, it has some sort of variation. We have blueprint projects, but still, it gives us a direction whether patient will have a good response to immuno or not by a proportion, not absolute value, but a proportion.
Yeah, exactly. I think we all been very convinced with the data that PDL1 as such does not rule out the use of immuno, but yes, it definitely helps us in deciding whether we can use immuno as a monotherapy or not, and as to what kind of response the patient will have. Coming to the role of immunotherapy in metastatic non-small cell lung cancer, especially Tecentriq as monotherapy, we have a for a reference, we have a case. Dr. Abhishek, the question is for you. Abhishek, Dr. Abhishek is with us?
नहीं सर, वो अभी लीव कर गए हैं सर.
Oh, is it? Okay, so we'll go back to Dr. Preeti. So we have a Dr. Preeti. So we have a 67-year-old lady, non-smoker, newly diagnosed with metastatic non-small cell lung cancer. Biomarker turned out to be negative. PDL1 high, more than 50% is the PDL1. ECOG performance status is 1. So, Dr. Preeti, how do you go about treating this patient? Metastatic NSCLC, high PDL1, 67
That's
years old, non-smoker,
yes.
biomarker negative.
67-year-old non-smoker, high PDL1, and biomarker negative. And the disease burden, if you want very rapid responses, then I would add chemotherapy. Otherwise, single agent immunotherapy is good to go.
So coming to single agent immunotherapy, talking about what are the options that you have in your mind? How do you plan about the single agent immunotherapy?
Single agent immunotherapy, either pembro, either atezolizumab, both, any of the two options are in my mind.
Okay, so Dr. Narayana Adhikari, how do you decide? As Dr. Preeti said that we have, if the burden of disease is high, I think then she will be preferring adding chemo to this patient. And if the burden of disease is not very high, not symptomatic, then single agent immuno is good enough for her. Do you agree with her? Are you comfortable with that
I do agree with
plan?
her, sir. Apart from that, I also look at the comorbidities and performance status of performance stage 1. I also take into consideration the comorbidities, renal functions. So in that case, it's platinum eligible or not. So taking all these factors into consideration, and if she's fit and platinum eligible, I tend to use chemo plus immunotherapy combination. Anyway, after 4 cycles, we have to continue with immunotherapy itself. And but if there are some relative contraindications or we are not very comfortable with giving chemotherapy, then definitely I would go ahead with single agent immunotherapy, preferably either atezolizumab or pembrolizumab. Both are approved in first line setting in that case, sir.
Yeah, I think fair enough. The only reason why I wanted to bring about the addition of chemo in more than PDL1 more than 50% was the response rates in both the scenarios. A patient having PDL1 more than 50%, if that patient receives single agent immuno versus receiving a combination of immuno plus chemo, the response rate have not been very different. So probably it's very, very important to be very sure when you plan to add chemotherapy to immunotherapy for a patient who has PDL1 more than 50%. A bad symptomatic patient, I think that is the only reason where we would be loving to add chemotherapy to immunotherapy, even if the PDL1 is more than equal to 50%. So, in a patient who has PDL1 high results, more than 50%, non-squamous histology, the chemo-immunomonotherapy, a chemo-immuno combination with a immunomonotherapy has not provided a significant difference in terms of overall survival and the median PFS. That is why probably just I was, and the response rates are almost the same. Difference is not more than 4 to 5%. So I think probably a highly symptomatic patient is the only reason where we would like to add chemotherapy to immuno if the PDL1 is high, that is more than 50%. So talking about the IMpower 110 trial, wherein which led to the approval of Tecentriq as monotherapy in PDL1 high population, metastatic non-squamous or squamous lung cancer patients. So this was a randomized phase 3 multi-center study wherein stage 4 non-squamous or squamous non-small cell lung cancer patients who were chemotherapy naive, EGFR ALK negative, ECOG performance status of 0, 1 were randomized to Tecentriq versus chemotherapy arm. A Tecentriq monotherapy arm was compared to the chemotherapy arm, and the primary endpoint was overall survival. And they found that those patients who had a PDL1 of more than equal to 50% had a significant improvement in the median overall survival of 20 months versus 13 months when it was compared to chemotherapy, with a hazard ratio of 0.59, suggesting a 41% reduction in the risk of death when single agent immunoatezolizumab was compared to chemotherapy in this high PDL1 population. Similarly, median PFS was also was 8.2 months versus 5 months in the atezolizumab versus chemotherapy arm, and the hazard ratio was also 0.59, suggesting a 41% reduction in the risk of progression when single agent atezolizumab was compared to chemotherapy in this group. Overall response rate also was higher in the atezolizumab arm, 40% versus 28.6%. Median duration of response was significantly better. It was 38.9 months in the single agent Tecentriq arm as compared to 8.3 months in the chemotherapy arm. So it shows the highest median duration of response as a monotherapy agent in first line metastatic NSCLC PDL1 more than 50% group of population. Coming to the safety profile, I think we have been using atezolizumab since a good amount of time now, and we all know the side effect profile of atezolizumab, which are usually grade 1 and grade 2 and easily manageable. So coming to Dr. Jitendra, if you are with us again, what is the opinion?
Yeah.
What is your opinion on PFS, overall response rate, and the duration of response data of the IMpower 110 trial? We can all the panelists can pitch in, please. Just a general
So
single sentence.
as we all know, that if disease burden and aggressiveness is taken care, probably IO gave a good PFS, a decent ORR, and a very good disease control rate. So that is with all IOs, and with single agent atezolizumab, we have seen that that was persistent in at least 2 trials. So that gives us confidence by using it single agent.
I think Dr. Preeti, your opinion on the IMpower 110 trial?
I'm sorry, actually, yes, IMpower 110 in high PDL1 positive subset, single agent IO, it has shown good results with improvement in overall survival and progression-free survival. Yes, it has become now, like in high PDL1 positive patient, one of the choice of the treatment.
Dr. Narayana Adhikari?
Yes, sir, I do agree. It has shown excellent PFS, OS, and ORR data. PFS is almost doubled, and OS is also quite good. And ORR, the duration of response is quite good, 38 months. So I think it should be our standard of care in first line PDL1 or 50% patients, more than 50% patients.
Okay, so the next question, I think we have already discussed high PDL1. I think we have options of atezo plus pembro. There have been differences in the trial design and the inclusion criteria of the pembro trial and the atezolizumab trial, looking at which probably it might help us in deciding what are the patients that we need to plan atezo for and what are the patients we need to plan pembro for. It is just how the trial designs have been planned. And the basic difference that we could look at was liver metastasis patients were included in the IMpower 110 trial, and they were contributed around 17% of the total patients, which were not there in the Keynote 024 or the Keynote 042 trial. Probably looking at this, 17% of the patients who had liver metastasis also did well with atezolizumab, and probably if a patient has liver mets, we have an option of using atezolizumab also for these patients as a single agent if the PDL1 is high. Again, coming to the data of IMpower Keynote 024 and Keynote 042 trials, I think comparing the cross trials, I don't think it's a very good idea to compare between the two trials. All the three trials were very well designed, and we are very convinced with the data of all the three trials. And using single agent immunotherapy, I think either atezo or pembro should do good for all our patients. How do you look at the results of these trials? Dr. Preeti, we can have inputs from you. Do we have Dr. Preeti with us? Dr.
Yes,
Narayan?
yes, yes. Yeah.
So looking at the three trials, the 110 Empower, Keynote 024, and Keynote 042, do you have any inputs from your side? Is there a way to decide on whether Atizo scores over Pembro or
Yes,
not?
I agree with you that comparing cross trial is not a good idea, and we cannot say that this immuno is better than this immuno. Cross trial is not a good idea, but both are the options for us.
I
So
think
it
given
opens,
both. Yeah, exactly.
it opens both the options for us, and I think this is the answer that these are two options.
Yeah,
I
I
don't
think I
think
think I, I'll go ahead.
Mhm.
I'll be totally in agreeing with you. I think, Dr. Narayan, do you have any opinion regarding the results of these trials? The three.
Yes, sir.
We have the differences in front of you.
Yes, sir. So numerically, although keynote one seems little bit more than the IM power, but again, as you said, we cannot have a cross trial comparison. And also, if we see the toxicity profile, generally we feel that PD-L1 inhibitors have lesser toxicity compared to PD-1 inhibitors. So that may score over pembrolizumab. But having said that, they both are equally good options, and we can choose one among them. Probably will keep the financial the less costly drug as a choice.
Okay, the good point that you brought about. I think we have data on that probably PDL1, the pneumonitis, is on the lower side as compared to PD1 inhibitors. We have a network meta-analysis. I think we have a slide on that. Okay, yes. So this is the slide wherein this also suggested the efficacy of the different immunotherapeutic agents in high PD-L1 population. This suggested that probably semipelimab was the most efficacious single agent immunotherapy that was in use when high PD-L1 population was considered, and then came atezolizumab, which was the second most efficacious agent. So I think it all depends on your personal experience with single agent immunotherapy, and I think you have multiple options with you in line, and it's just that how what is your experience, personal experience. I think that is the thing that matters the most. There is one real world data also on the safety of PDL1 versus PD1. It suggested that with the PDL1 inhibitors, only 1.6% of the patients had pneumonitis, as compared to 5.1% of the patients having pneumonitis with pembrolizumab, and 4.5% of the patients having some form of pneumonitis with nivolumab. So in the real world study of older adults aged more than 65 years in Japan, rates of pneumonitis were significantly lower with Tecentriq as compared to pembrolizumab. I think this is a real world data, but as I said, personal experience with the single agent immuno is what matters the most. We also have the ESMO magnitude of clinical benefit scale, which suggested that Tecentriq monotherapy scored 5 out of 5 when monotherapy was used for metastatic non-small cell lung cancer patients having high PD-L1 status. Coming to one more just case scenario for our references, 65 years male smoking history. So we have this question for Dr. Preeti and Dr. Jitendra. Do we have, Dr. Jitendra and Dr. Preeti, we have a 65-year-old male, stage 4 non-small cell lung cancer, PD-L1 expression 60%, ECOG performance status of 2. So this is the most common scenario that we see in our clinical day-to-day practice. Okay, so comorbidities: moderate COPD, ischemic heart disease, patient already on dual antiplatelet therapy, having dyspnea on exertion, mild weight loss, and fatigue. So how do you want to treat this patient? An ECOG performance status of 2, considering the trials that we have been reading, most of these trials included ECOG performance status patients of 0 and 1 when we talk about single agent immunotherapy. Dr. Preeti and Dr. Jitendra, you can pitch in, please.
So yes, the patients with stage 4 lung cancer, which is the commonly seen, are patients which are poor performance status like PS2 and more. And most of the trials have excluded such patients. They have included only PCOX performance status 0 and 1. So we have. एक मिनट गौतम
Dr.
So we
Narayan?
have,
Yes, yes.
yeah, we have data from atezolizumab, which can be used as a single agent immunotherapy in patients with poor performance status. Yes, The atezolizumab is one of the immunotherapy which can be used as single agent in poor performance status patients.
Okay, Dr. Narayan, Dr. Jitendra, anything from your side? How do you see this patient being treated at your clinic?
Yes, sir, I agree.
So see, usually the problem with lung in single agent IO means although we see 10 metastatic patients, out of them only one or two will be there, which we can use for single agent IO. Because many of those patients will have some sort of symptoms. Meanwhile, the NGS comes, you have to start some sort of chemotherapy. Still, if somebody is with a low burden disease, who diagnosed as stage 4 patient or who doesn't want to have a chemotherapy, probably immunotherapy with atezolizumab can be given.
Dr. Narayan, I think point well taken, Dr. Jitendra. Most of our
Somani
patients
sir
want.
has put one question in the chat that if PS improves, you want to add IO. So you want to add chemo. So if PD-1 is better, more than 50%, probably I would not try to add any chemo if patient PS improves.
All
Yes,
right,
sir.
Dr. Narayan, what is
Yes,
your
sir.
take on this?
So these are the type of patient where we would prefer a single agent immunotherapy. And if we have the NGS report at hand before starting the treatment, then definitely I'll go ahead. When all the driver mutations are ruled out, I'll go ahead with single agent immunotherapy. But if I have to wait the results of the driver mutation, then maybe start with very low dose weekly kind of chemotherapy. Then maybe switch to single agent immuno when the NGS reports come. So these
So,
are the type of patients where single agent immuno would be the preference.
so single agent immuno, we do have a good data as per the Ipsos trial, which was done in ECOG performance status 2 patients, saying that atezolizumab was much better than chemotherapy in these patients. So how convinced are you with the Ipsos trial design and the data?
So design is very good because this is the only trial which was taking consideration only IO versus chemotherapy. Other trials present who were positive were only for a subset analysis. So that is shows us the confidence in the molecule because other phase 2 Pembro data was not able to suffice the outcome and other data are not that much strong.
Exactly. Although we have seen NCCN recommending single agent immuno, we have not seen the as robust data as for atezolizumab in ECOG performance status 2 patients. And I think Ipsos trial has a well designed trial, and we are convinced with the data, and probably using atezolizumab in our ECOG performance 2 patients as per the Ipsos design is very convincing. Dr. Preeti, your take on the Ipsos trial.
So the data is convincing for use of single agent IO. The patient is affordable. The patient has poor performance status. And this gives us one of the option other than best supportive care. The patient has one of the option, and it has shown an overall survival of almost a year. So that is a good data, and I think this is one of the option that allows us to give to the patients with poor performance status.
Yeah, I think a better option rather than giving chemotherapy, you can give immunotherapy for patients irrespective of the PDL1. That is, I think, the uh, a good impact of the Ipsos trial. I think.
Ankit, we have Dr. Somani sir also if he wants to comment something on it. I think
Also,
he's
please,
looking at
please.
it. Sir,
सोमानी सर ने एक साल पहले
anything.
एप्सॉस पढ़ाया था मेरे को याद है
That's why I think, sir, any
I
एप्सॉस
was
comments from your side, sir?
I was
Any
waiting.
I
Because
was
comments
Somani sir,
from your
I
side?
was
अंकित
waiting. How come
अंकित
Somani sir has
अंकित
not
सर
pitched in?
नहीं
Please, sir,
सर ने
please,
ग्रुप
please.
में डाला है बट सर ने एप्सॉस पढ़ाया था मुझे अच्छे से याद है
Thanks, Jitendra, for remembering and commenting that way. Thanks, Pulkit, for allowing me. Only thing is, we really need to differentiate the poor performance status. If patient
Yes.
is rapidly deteriorating because of the burden of the disease, sort of clinical crisis, then these patients are unlikely to respond. So before you commit patient or family with such costly medicine that this is approved treatment, probably you will not get it. Only frailty because of the age, because of the comorbidities, because of the other reasons, and you feel the burden of the disease is not that much, where you feel that you can have the enough time, like 2 to 3 cycles time, then probably you should advocate or you should counsel the patient that the single agent immunotherapy and this particular drug is being approved based on the available data. The other competitive molecules like pembrolizumab are not approved. Rather, they have shown the deteriorating or the inferior result in the similar setting. So
Absolutely.
that's my message I want to tell
One more
that try to
comment over
give
this, because so we have many mutation which indirectly suggests us that this patient will not be responding to iode, like escape STK11. So probably in those we have to be cautious and try to add chemotherapy at least for 12 weeks or something like that.
What about adding Nivo EP for these patients who are STK11 or P53?
That's
Probably,
that's
probably.
one of the ways you have to
Yes.
do more than the
Yes,
single agent immunotherapy.
yes.
That can be logically, as Jitendra said, that they try to give chemotherapy so that initial resistant clones can be taken care of. The other way is that chemo light plus IO or IO plus IO, depending on the suitability and what is your own experience and the personal preference. You should be ready
Perfect.
for the
Perfect.
toxicity management. Moment you go beyond the single agent IO like chemo plus IO or IO plus IO or chemo light plus IO plus IO.
Absolutely, sir. It's very, very important for us. And I think it's very easy for a lot of people or a lot of clinicians to label the patient as poor performance status just because of the disease burden. That is, I think that practice should not happen. That hampers the treatment plan, and that gives an under that is a major reason for under treatment of a lot of patients. I totally agree with you, sir. Thank you so much for pitching
And
in.
the reason for that is that many times we miss the incorporating the best supportive care right from the
Absolutely.
beginning, from the day one. Like when you are committed to give the pemetrexed, you start day -7 the folate or the B12 neurobion or something like that. The best supportive care should start right from there before you prescribe the I say biopsy, before you advise the PET CT scan. Moment with the available information, you feel that the patient is suffering from the lung cancer, the first part should be taking care of these respiratory pain and the appetite and other parts, like BPH of the patient, managing it. Because every treatment takes some time to get the improvement.
Totally agree, sir. Totally agree. I think that is where the role of palliative care departments also comes into picture. I think it's all a multidisciplinary discussion and the treatment plan whenever the patient has been started on treatment. Okay. So coming to the next phase of our discussion, I think we'll just move on to the subcutaneous dysentery. I think that is the recent addition to the armamentarium again of the for management of a patient. So I'll discuss with. I'll have a just a brief comments from all our panelists, starting from Dr. Jitender. Subcutaneous dysentery. How do you feel that this will change the way we are dealing with immunotherapies for our patients? How do you see the future with dysenteric subcutaneous form?
So Roche has launched Phesgo also, which is substitute a longer version. So it is easy to give, easy for the patient to get used to. Uh, disease usually doesn't decrease, but it decreases the time of administration, time of admission. So if subcute is equivalent, then probably subcute is the better for patient. Like we
We
use
do, we do
Lasgis
have a trial.
Fasco, we use Phesgo.
Yeah,
So we
we do
have
have a
multiple
trial.
now.
So we do have a
Yes.
trial that has shown that the subcutaneous form of atezolizumab has the same pharmacokinetic profile as the intravenous form, and the data also suggests that the results have been similar between the both the routes of administration. So taking that into consideration, how do you are you
Sorry
convinced?
to interrupt you, sir.
Just 2
Sorry
minutes.
to interrupt, sir.
Yes,
Please
thank you. Yes,
conclude the
thank you.
session.
2 minutes, 2 minutes, yes. So, Dr. Preeti, Dr. Abhishek, Dr. Narayan, are you willing to switch your patients from IV immunotherapy to subcutaneous form when Tecentriq subcutaneous has been into the market now? How do you see Tecentriq subcutaneous?
Yes, sir. It seems promising, and the data are convincing regarding the pharmacokinetic and the clinical data also. So I'll definitely switch if the patient is ready and the finances are just like equivalent to the IV formulation. Then I'll definitely switch to the subcutaneous injection, decreasing the transfusion time, and the patient also will be quite comfortable with the formulation. So I am convinced to, if available, I'll definitely plan switching to subcutaneous form.
Dr. Preeti, your comments, please.
Yeah, it can be used. especially in the patients we want to avoid volume, in the patients you want to have a rapid turnover time, like if you have daycare beds not available, you want to rapidly discharge the patient. This can be substituted, as we have substituted some patient to phase go. So it can be substituted, but it
Okay.
is one of the options. I was not completely gone away.
Okay. Okay. I think we'll close the discussion. I thank all my panelists. Thank you for giving your inputs. Thank you, Tanvi, thank you, Pulkit, and thank you, Pulkit, for having us here. Thank you.
Thank you, sir.
Thank you, Dr. Ankit, for a nice moderation and very illustrative and very uh, academic discussion. And in the interest of time, we will move forward for the next session. Next session is sponsored by the Zydus. And the speaker is Dr. Ashish Daima, consultant medical oncologist, Kshetrapal Hospital, Ajmer, and he will be delivering the lecture on the response driven management of the HER2 positive ABC fueled by update data of TDM1. Dr. Ashish, over to you.
Hello, am I audible?
Yeah, very much audible.
Yes,
Please
sir.
go
Hello, sir.
ahead.
Yes.
Good afternoon, sir. Good evening, sir. Yes, sir. Slides. Slides, please.
Sir, Shekhar, just.
Sir, the slide is visible.
Yeah. Hello. Good evening. Good evening, all. Response-driven management of HER2 positive early breast cancer. Next slide, please. The prognosis of HER2 disease is poor without any HER2 targeted agent. In view of HER2 disease positive has shorter disease-free interval and shorter OS. So we need to, next slide. So we need some HER2 targeted agent. Right now we have 8 HER2 targeted agent antibodies like trastuzumab, pertuzumab, margetuximab, and TKI, lapatinib, neratinib, and tucatinib. And we have some ADCs like TDM1 and TDX. Next slide, please. Anti-agent trastuzumab did well in last as a adjuvant therapy. Next slide. Next slide. There are some trial, HERA trial, NSBP 31 and BRIC suggestive of using of trastuzumab as a adjuvant therapy, increase DFS and OS benefit both. So we need to add adjuvant any HER2 treatment for patient in adjuvant therapy. Next slide. But the risk of recurrence after only using trastuzumab, so we need to minimize risk of HER2 positive in early breast cancer. Next. So definition of the high risk HER2 early breast cancer, the risk of more than 10% of recurrence in patient who taking any neoadjuvant chemotherapy, any HER2 positive therapy, if patient having residual disease is high risk, and if patient underwent upfront surgery, any node positive disease, any T4, T3 with node positive is high risk. So next slide, please. So we can personalize the approach of reduce of recurrences. Next slide, please. Next. How will we do personalized? We will do after giving neoadjuvant therapy and segregate from who patient who receive PET-CR or residual disease. Next slide. These are the trial suggestive of increase in PET-CR compared to with residual disease in increase of 3-year DFS and EFS by approx 90% versus 83 in multiple trials. Next slide, please. Neoadjuvant therapy, which patient should be considered? Next slide. The indication of neoadjuvant therapy is obvious, is like inoperable disease, inflammatory breast, T4 and 3 and 2 bulky disease, and operable disease, which has a HER2 positive, T2 and N1, or selected patient who has T1C and N0, and patient want to breast conservative surgery and N1 disease likely to weaken N0. These are the indication of neoadjuvant therapy. Next slide. HER2 positive breast cancer with residual disease have poor outcome.
These two graphs suggestive of who patient with the PATH-CR having decreased event-free survival rate comparatively with PATH-CR, and second also suggestive with the same OS is decreased in patient who is having PATH-CR, increase in PATH-CR. Next slide, please. The addition of anti-HER2 therapy approval in adjuvant therapy. First is trastuzumab pertuzumab used in combined with the chemotherapy neoadjuvant therapy patient and HER2 positive early breast cancer more than 2 centimeter node positive and adjuvant treatment patient with high risk of recurrence. Same as TDN1 as adjuvant therapy patient for, with having residual invasive disease. We need to use TDM1. Niraparib approved in July 2017 extended adjuvant therapy for patient HER2 overexpression for trastuzumab therapy. Next slide. The access of three therapies in India, like we have niraparib, pertuzumab, and TDN1. Biosimilar available in pertuzumab and TDM1. In India, most of the high-risk patients undergo only for trastuzumab adjuvant therapy. Next slide. The trial is Catherine design, multi-center randomized control trial. It show the primary all patient given neoadjuvant therapy with dual HER2 blockage, residual disease, the patient having residual disease, segregation ratio by 1:1 in TDM1 and trastuzumab. Primary endpoint was disease-free, invasive disease-free survival or OS. After 3 years of this trial, that suggestive of increase in invasive disease-free survival by 88% compared with the 77% with trastuzumab. At that time, after 3 years, no OS benefit seen, but after long-term data of 7 years. Next slide, please. Next. Next slide suggestive of after 7 years, the invasive disease-free survival increased from 11 to 13.7%, and next slide, please. One OS benefit also increased from 4.7%. So the Catherine, the patient who not receiving PAT-CR adjuvant TDM1 increased invasive disease-free survival plus OS with after with trial. Next slide, please. The Catherine trial subgroups. It is shown the hazard ratio is less than 1, almost all subgroups. So it is all beneficiary and all type of subtype of breast cancer. Next slide, please. Next. Yeah. So how to back, please. Yeah. So how these results are important in the HER2 positive breast cancer. Newly diagnosed is high risk HER2 positive breast cancer. Now we give trastuzumab, pertuzumab, and neoadjuvant chemotherapy, then followed by surgery and assessment. If residual disease not there, PAT-CR achieved, we continue with dual anti-HER2 blockage, pertuzumab and trastuzumab. If we we have in residual disease, an opportunity to tailor the treatment by TDM1 and as a adjuvant setting. Next slide. Skip 2 slide, please. Next, please. The strategy to managing patient with stage 3 HER2 positive breast cancer. If we have direct T2 and positive, we start with dual anti HER2 blockage. If we having PAT-CR, we continue with the trastuzumab pertuzumab. If we have residual disease, TDM1 with 14 cycle. If we have early diseases like T1 and 0, we surgery. And if we see if it's only only T1, no and 0, only trastuzumab plus paclitaxel 12 cycle. And if we have any node positive, we should consider for switch to dual HER2 blockage, trastuzumab and pertuzumab. Next slide, please. Summary. For the patient of HER2 positive breast cancer, ability of HER2 targeted agent may markedly improve the overall outcome. Need to be offered neoadjuvant therapy of all eligible HER2 patient, and Catherine trial suggestive of residual disease therapy for patient with residual disease after neoadjuvant taxane and trastuzumab with more confidence data, increase interval DFS and OS benefit. Thank you so much.
Thank you, Dr. Ashish. Thank you. Thank you. Thank you.
Thank you.
So I think we have come to the end of the breast cancer session, and I think we are good to go ahead with our second session, that is the lung session. And we already have the chairpersons on the board, respectable Dr. Naresh Somani, sir. Good evening, sir. Once again, welcome, sir.
Good evening. Good evening.
And our very respectable dear Dr. Pawan Agarwal, sir. Welcome, sir, and good evening, sir. And thank you for joining, sir.
Good evening. Thank you. Thank you for inviting me also. Good evening.
Yes, yes.
I'm
And I
listening
would
from the first lecture. Is almost going very good. Very good. Every
thank you,
speaker
sir.
is very
Thank you.
good.
Thank you. Thank you, sir. And I would request both the chairpersons to kindly move forward the further lung cancer session. Over to you, sir. Over to you.
Thanks, Dr. Pulkit, for this opportunity. Let me
Thank you, sir.
congratulate you first, not only for conducting this meeting, but probably this is the first meeting that you have designed in a broader
Yes, sir.
way and you are making it possible. And I hope that soon you will be making the meaningful, senseful physical meeting or the offline meeting also very much required now on the
Thank you, sir.
focused topics. And I wish you best for the meeting and for your future. And I will request my co-chairperson, Dr. Pawan Agarwal, to
Thank you, sir.
call upon the speakers and introduce the topic. Over to you, Dr. Pawan Agarwal, sir.
Thank you, Dr. Pulkit and Dr. Naresh Somani. So next session is for lung cancer, and first three presentation is an abstract presentation, and that is given 5 minute each. So I request to all speaker, please stick to the times because we are all running a little late. So first in lung cancer, the Harmony 6 invasive plus chemotherapy and tislelizumab plus chemotherapy in first line non-small cell lung carcinoma. And that presentation going to be present by Dr. Rohit Swami, is our again young consultant medical oncologist, Narayana Multispecialty Hospital, Jaipur. And Dr. Rohit, please start your presentation. Rohit Swami.
Yeah, good evening, Somani sir and Pawan sir. And thank you, Pawan sir, for such a generous introduction. And thank you, Pulkit, for giving me this stage to present this study.
Thank you, sir,
So,
and welcome.
yeah, so I'll ask the organizer to please share my slides. Yeah, so I will be presenting Harmony 6 study. Ivonescimab with chemotherapy against Tevimbra with chemotherapy in first-line setting in metastatic or advanced squamous cell carcinoma lung patients. Next slide, please. So if we come to background, so there are several PD-L1 inhibitors which are approved along with combination with chemotherapy in metastatic advanced squamous cell NSCLC, and even Tevimbra with chemotherapy has been approved with European Medical Association as well as Chinese Medical Association in combination with chemotherapy in metastatic squamous cell NSCLC. So now we have this new bispecific antibody which target both PD-1 as well as VEGF inhibitor. So this is ivonescimab, and it is bispecific antibody which targets PD-1 as well as VEGF. So it is approved in patient in non-squamous NSCLC who had experienced disease progression post first-line EGFR TKI therapy, and after the Harmony A study, and after Harmony 2 study, it also got approved for all the patients of metastatic NSCLC with PDL1 more than 1% in a first line treatment along with chemotherapy. Now, Harmony 6 study compared Tevimbra and chemotherapy along with this ivonescimab plus chemotherapy. Next slide, please. So it was phase 3 study, 1:1 randomization was done, and only pathologically confirmed squamous cell carcinoma, EGFR ALK negative, stage 3B to 4, and good PS patients were enrolled in this study and randomized into 1:1 patient to paclitaxel plus ivonescimab to as compared to Tevimbra with paclitaxel. These were further substratified according to stage 3B, 3C or metastatic disease and as per PDL1 status. And after completing 6 cycles of 4 to 6 cycles of chemotherapy with immunotherapy, 2 years of maintenance of immunotherapy was given. Primary endpoints were PFS by independent review committee and secondary endpoints were overall survival. Other secondary endpoints were PFS by investigator, overall response rate, disease control rate, duration of response rate, and safety data. Next slide, please. Coming to statistical considerations, so estimated sample size was around 528 to provide around 86.3% power for PFS, assuming hazard ratio of PFS by 0.7 and 80% power for overall survival, assuming overall survival hazard ratio of 0.73. And hierarchical testing approach was done and one interim PFS analysis was planned. So this presentation is that pre-specified PFS interim analysis only and overall survival was not mature at this time. Next slide, please. So patient disposition was done as per this chart. Around 162 patients are still on treatment with evonesimab as compared to around 134 patients on Tevimbra. After this, at this point of interim PFS analysis. Next slide, please. Baseline characteristics were well matched in both the arms. Majority of patient, around 75 to 80% of patients were metastatic, and majority of patients had PDL1 1% or more than 1%, which was around 60%. And less than 1% of PDL1 population was around 40% in both the arms. Metastatic sites were liver metastasis, brain metastasis, and more than 3 metastatic sites. Next slide, please. So coming to primary endpoint, PFS assessed by independent review committee, evonesimab plus chemotherapy demonstrated significant improved PFS as compared to Tevimbra plus chemotherapy with hazard ratio 0.60, representing around 4.2-month improvement in median PFS. So median PFS in evonesimab arm was around 11.14 month as compared to Tevimbra arm, which was 6.9 month. Hazard ratio was 0.78. And this consistent PFS benefit by investigator assessment was also there. So investigator assessment PFS benefit was also there with hazard ratio of around 0.64. Next slide, please. Coming to subgroup analysis, this PFS benefit was seen across all the subgroup, whatever the stage was, whatever the PDL1 status was there, and whether there was 3 or more than 3 metastatic site, liver or brain mets. Each and every subgroup of the patient had significant PFS benefit as compared to Tevimbra. Next slide, please. And if we come as per PDL1 status, so PDL1 less than 1% or more than 1%, 1 to 49% or more than 50%, all of these subgroup patients had significant PFS benefit with the addition of ivonesimab as compared to Tevimbra. Next slide, please. Coming to tumor response, so there was significant overall response rate in with the use of ivonesimab as compared to Tevimbra. With the p-value of 0.008, and this overall response rate was maintained both in TPS less than 1 or TPS more than 1%. Similarly, duration of response, there was significant benefit in duration of response by the use of ivonesimab as compared to Tevimbra. Next slide, please. Coming to treatment-related adverse event were almost similar in both the groups. Grade 3, 4 treatment-related adverse event were 63% in evonesimab arm as compared to 54%. Serious treatment-related adverse events were almost similar in both, 30%. And leading to discontinuation of treatment was also similar, 3.4 to 4.2%. And treatment-related adverse event leading to death was around 3% in both the arms. And most common treatment-related treatment-related adverse events were related to chemotherapy and autoimmune side effects of these both immunotherapies. Next slide, please. So if we come to immune-related adverse events, so both the arms, evonesimab as well as Tevimbra, both showed almost similar incidence of immune-related adverse events. And grade 3 immune-related adverse events were around 10% in both the arms. Similarly, serious adverse events were around 9% in both the arms. Leading to discontinuation was more in Tevimbra as compared to ivonescimab, but was not significantly high. But the VEGF inhibitor effect of ivonescimab lead to more VEGF-related adverse events. Around 27% of patients had proteinuria of any grade, where a grade 3 was 2.3%. Hemorrhages or more in ivonescimab arm as compared to Tevimbra, and hypertension was more in ivonescimab arm. So immune-related adverse events were similar, but vascular endothelial growth factor receptor blockage related adverse side effects, which we see with bevacizumab, also were significantly high with ivonescimab. Next slide, please. So concluding this Harmony 6 study, there is significant PFS benefit in first interim analysis of PFS with ivonescimab as compared to Tevimbra. Tumor response rate was higher. Duration of response of tumor was also better in ivonescimab as compared to Tevimbra. Overall survival data is not mature at present, and this ivonescimab plus chemotherapy can become a standard of care for the first line metastatic or advanced squamous cell uh, non-small cell carcinoma lung. Thank you everyone.
Thank you, Dr. Rohit Swami. I think everything has been explained. So I don't think any any listener have any query. So we just move on to next presentation. That is a North Star study, the phase 2 randomized study of the osimertinib with or without local consolidation treatment in metastatic EGFR mutant non-small cell lung carcinoma. And this study is going to be present by Dr. Satyajit Soni. He is an associate professor, medical oncologist. Dr. Satyajit Soni.
Yes, sir. Good evening, all. Thank you, Dr. Pulkit and organizing team, giving me an opportunity to speak on some topic. And my topic of presentation is today's North Star study. One second. Can you share the slide from that slide? Advanced. Yeah. So I have to speak on the North Star study, which was presented in the ESMO Congress in the Berlin. So this is the study which added the local consolidated therapy to the osimertinib for the metastatic EGFR mutated NSCLC patients. Next slide, please. Next slide. So this is the background of study. We all know the EGFR mutated metastatic NSCLC patient treated with EGFR TKIs eventually develop resistance and the disease progression. So combining or both improves the outcome in the patients with the oligometastatic NSCLC, and combining this TKI with LC local constant therapy may eradicate the resistant clone and the delay systemic progression. So however, the prospective data are lacking. So next slide, please. So this is the study design of this is the randomized multicenter phase 2 trial. Key eligibility criteria for this patients. This study was the locally advanced or the metastatic NSCLC patients with good ECOG PS and the measurable disease with TKI naive patients with EGFR, for example, DEL19 positive or L858R mutation positive, or those were treated with first and second generation TKI developed the acquired T790M mutations, and the stratified on the basis of the TKI naive or the prior use of the first generation or second generation EGFR TKI, and on the basis of the number of metastases and the partial response versus stable disease and the brain metastasis. So post induction with osimertinib for 6 to 12 weeks, those patients not progressed randomized 1:1 ratio with osimertinib and osimertinib plus local conservative therapy, with the primary endpoint of the is PFS, and the key secondary endpoints are the safety data and overall survival, and the PFS in the subgroup in the patients with up to 3 metastasis and the TKI naive. Next slide. Next slide, please. So the demographic and the baseline characteristic of the study, all baseline characteristics are all almost comparable, but we can see here the majority of the patient have exon 19 deletion, and most of the patient, more than 95% of patient were the TKI naive, and more than two-thirds of the patient had greater than the 3 metastases, either in the baseline as well as in the randomization, and the one-third of patient had brain metastasis, and the almost two-thirds of the patient had the partial response to the induction osimertinib. Next slide, please. So we can here see the extent of the metastatic disease. Almost 30% of patient had oligometastatic disease, remaining had polymetastatic disease, and the nearly 1/4 of the patient had pleural effusion also. Next slide. So what local consolidated therapy were used in this study, that either in the form surgery, radiation, or combining both. Nearly 60% of patients had underwent the radiotherapy to local site, as well as nearly 30% of patients had surgery, and remaining had combination of surgery and radiation both. Next slide. Next slide. So we can see here the treatment related adverse events. Previous slide, please. Previous slide. Almost majority of patient had grade 1 and grade 2 toxicity only, and if you see the more than 50% of the patient had toxicity in the terms of diarrhea or fatigue and the skin disorder and the nail disorder. So very less number of patient had grade 3 toxicity in the either arm. Next slide. No grade 4 or no grade 5 toxicity were found in the even in the with patients with those combined with local consolidatory therapy after use of osimertinib. Even we can see the pneumonitis risk was also not increased. Next slide. So we can see here the PFS, that is absolute difference of nearly 8 months with a good hazard ratio of 0.66, and with significant p-value. Median PFS with the local therapy is 25.3 months. Next. Next slide, please. So on the basis of EGFR mutation subtypes, the majority of patients were aware of the exon 19 deletion. So that median PFS difference is also markedly difference between both subtype of mutations. Like osimertinib with the local consolidated therapy had provided nearly 40 months of PFS in the exon 19 deletion. If you see the L858R, it was nearly 20 months of the PFS, which was also significantly better than the osimertinib alone. Next slide. If you see according to number of metastases, lesser number of metastases did better than the higher number of metastases. Next slide. So this is the baseline. Nearly 30% of patients were presented with oligometastatic disease, and remaining 70 with polymetastatic disease. Post-induction with osimertinib, that out of the 71% patient of polymetastatic disease, nearly 13% of patient had comes to the induced oligo, means there is a very good control of extensive disease, and which ultimately turn over to the induced oligometastatic disease. And after that, they are randomized to local consolidated therapy. So all of oligometastatic disease patient completed local consolidated therapy, and the 71% of the induced oligometastatic disease completed the local consolidated therapy. Among the polymetastatic disease, the 56% of patient completed the local consolidated therapy. Next slide.
Dr. Satyajit, please be fast. We are crossing the time.
Next slide. If we send the PFS in the according to whether they completed or partially treated with local constitutive therapy, the median PFS was nearly 28 months with complete local therapy, which was way better than the partial local therapy. Next slide. So I'm concluding this my presentation in the patient with EGFR mutated NSCLC. The osimertinib with local therapy improved the PFS. The benefit of this adding local therapy was observed across the all disease burden subgroups, and the no excess toxicity was observed in the particular, and there was no even increased rate of the pneumonitis beyond that expected with thoracic radiation. So these findings support the osimertinib with local therapy as a safe and effective strategy to extend disease control and the delay systemic progression in advanced disease of metastatic NSCLC of EGFR mutated. Thank you.
Dr.
Thank
Soni,
you.
a quick question to you.
Yes, sir.
What is the best time to incorporate the local therapy in a responding patient and a patient who initially presents with a pleural effusion, but let's say after 3-4 months, pleural effusion has gone? Will this patient you will incorporate for the local therapy?
Sir, as per my experience, we usually don't. I have never used local therapy in responding patient. We use local therapy in the oligoprogressive disease only. Once there is a progression happen, oligoprogression happen, and then we add the local therapy to the oligometastatic site if they are the if it is feasible.
Uh, I think this is the best possible answer of these studies, because if disease is progression without multi point, then there is no point to give osimertinib plus local treatment. You have to shift the second line treatment. So basically, oligo, if you can go for the surgery or can be radiotherapy or the local point of the bone or the mediastinum or the brain metastasis, or even the local point, or you can do the wedge resection or lobectomy if oligometastasis. Either otherwise, no use of this study. Thank you. I think Somani ji, this is the probable answer. And can we move the third presentation? And that Dr. Mukesh Rolania, Assistant Professor, Medical Oncology and Hematology, State Cancer Institute, SMS Hospital. And he will be presenting the ELEVATE study, the study backbone of intermittent adjuvant therapy in a resected ALK non-small cell lung carcinoma. Dr. Mukesh Rolania.
Thank you, sir, for introduction.
Yeah.
Thank you, organizer, Dr. Pulkit, for giving me an opportunity. So,
Welcome, Dr. Rolania. Welcome.
Thank you. Thank you. So, share my slides, please. So my presentation is which already presented in ESMO 2025 in Berlin. That is ensartinib adjuvant therapy in patient with stage 1B to 3B, ALK positive in non-small cell lung carcinoma after complete tumor resection. This is phase 3 study. ELEVATE. Next. So as you know, ALK fusion have been identified approximately 5 to 7% of early stage NSCLC, and standard of care is currently surgery followed by ALINA study. Again, ensartinib is a highly selective ALK inhibitor that has been approved in advanced ALK positive NSCLC in China and US based on ISALT study. But this is for early stage lung cancer. This phase 3 which is presented in ESMO 2025. Next slide, please. This study stratified according to histological states 1B, 2, 3, and 2. Patient who have prior received adjuvant chemotherapy and then randomized into ensartinib versus placebo. And follow-up is baseline and every 12 weeks for the first 2 years, and then every 24 weeks until the occurrence of disease recurrence. And primary endpoint of this study is DFS, and investigator assessed DFS, OS, and safety. Next slide, please. So baseline characteristics are well balanced in both arms and in ensartinib and placebo. Next slide.
So in this study, ensartinib showed an improvement in DFS in patients with stage 2 to 3B. And this is statistically significant. DFS hazard ratio is 0.2 only. Next slide. Again, ensartinib showed an improvement in DFS in patients with stage 1B to 3B disease. And this is investigator assessed DFS. Again, the DFS hazard ratio is 0.20. Next slide. And this DFS benefits favoring ensartinib was consistent across all subgroup in the trial, whether they are old or young, whether they are male or female, whether they are smoked or not smoked, does not affect according to ECOG performance stages. And all patients, whether they are stage 2 or 3, all are responded, whether they are received adjuvant chemo or not. So all patients are responded to this drug. Next slide, please. Coming to safety. So at least one treatment emergent adverse event are reported in approximately 99% in the ensartinib and 92% in the placebo arm, and majority of grade 1 and 2. One grade 5 treatment emergent adverse event is cerebral hemorrhage reported in the ensartinib, but were not due to ensartinib related. So majority of side effects are usually like TKI, like hip, that is SGOT, pit increase, races, skin toxicity. That is common with other TKI also. So no other unique side effect with this drug. Next slide. So coming to conclusion of this presentation, adjuvant ensartinib showed significant and clinically meaningful DFS in patients with stage 1B to 3B, all positive NSCLC as compared to the placebo. Primary population, which is stage 2 to 3B, DFS is 0.2. ITT, again, DFS is 0.2. So DFS prolonged with ensartinib across all subgroups, including those with histological stage 1B, 2, 3, and 3B disease, and who received prior adjuvant chemotherapy. And no new safety signals of ensartinib was noted in the adjuvant setting. Thank you.
Thanks, Dr. Mukesh. And we all understand that presently in the adjuvant setting or consultation setting, we have the different treatments like IO, durvalumab, or EGFR, osimertinib, or alectinib, or ensartinib kind of the drugs. So it's really important that we dissect out our patients right from the beginning, do the proper NGS, and we try to segregate those patients for the appropriate treatment. And I will stand corrected for Mukesh Ulania. I believe that he is now associate professor.
Yeah. No, that is no issues. ये क्या इसमें क्या है सर?
So good
ये
luck.
एक बार माइंड में घुस जाता है सर, वो आ जाता है क्या है?
No, very soon you will be the professor also.
Yeah.
Yes, sir.
God bless you. God bless you.
Over to the
So,
organizing team. Thanks.
yeah.
Thanks.
Thank
So
you so much,
next,
sir. Thank.
So next session, thank you, Mukesh. The next session is a sponsor session by Pfizer, and that going to present Dr. Sanjana Chaudhary. She is a consultant medical oncologist, SMS Hospital, and she is going to present again the ALK Odyssey, tracing the path from the diagnosis to innovation. Dr. Sanjana, there is a little bit change, and after that, Prashant Kumbha's presentation will be coming up. So, Prashant, you will be ready. And Dr. Sanjana, please start your presentation.
Dr. Sanjana, you are mute. You are mute. Unmute yourself.
Am I audible?
Yeah.
Yeah. Welcome.
Good evening, everyone, sir. Thank you, Pulkit sir, for giving me this opportunity. And today I'm here to discuss the first line management of ALK rearranged non-small cell lung carcinoma in metastatic setting. Sorry, just one. My slides are not moving. Just excuse me, just 1 second. Is my screen visible?
Yes, ma'am, visible.
Sorry, slides are not moving by my side. Please, can you share from your side? Um, is it visible? Hello? Hello? Am I audible?
I think the organizing team has shared the slide.
Okay,
You
sir.
can just ask them to move the slide.
Yes, sir.
And you're audible.
Okay, thank you, sir. So today we are discussing the first line management of ALK rearranged metastatic non-small cell lung carcinoma. So lung cancer, according to Globocon 22, is the fourth most common cancer diagnosed in India, and 7.8% of the all cancer-related death in India is due to lung cancer. So ALK gene rearrangement in seen in the 1.6 to 11.7%, that is after EGFR, is the second most common targetable mutation in lung cancer. So 5% of all non-small cell lung carcinoma are positive for ALK mutation that are typically adenocarcinoma, non-smoker or light smoker, and more common in the younger patient. And the EML for ALK and EGFR mutation are mutually exclusive. So, CNS mets are occurring in the 20 to 40% of untreated ALK positive non-small cell lung carcinoma. So, there is an unmet treatment challenges with the availability of the second generation ALK TKIs, that the ALK resistant mutations are more frequent with these, and the CNS mets, that is inadequate penetration with the first and second line ALK TKI. So the durable control of the brain mets in patients with the brain mets and preventing the brain mets in those without them at the point of diagnosis is a remaining unmet treatment need. So there is a need for additional ALK TKI that prevent the emergence of resistant subclones in untreated patients. When we look at the cumulative incidence of the brain mets, the 3-year cumulative brain mets is found in the 58% of the ALK positive patients, and the baseline 24% ALK positive patients have 24% baseline brain mets. So when lorlatinib is a selective ATP competitive, highly potent third generation ALK TKI with a excellent brain penetration of about 75% to address the brain mets. So with an overall good intracranial and oral activity in patients with previously untreated ALK positive advanced non-small cell lung carcinoma. So the CROWN trial, that is the phase 3 study design for lorlatinib. So the key eligibility criteria are stage 3B and 4 ALK positive non-small cell lung carcinoma with no prior systemic treatment for metastatic disease with ECOG PS of 0 to 2, and the asymptomatic treated or untreated CNS mets are permitted in this study.
Dr.
And
Sajna, sorry for interrupting you. I think the slide presentation flow and your is little lacking. Organizing team can kindly
I'm
take care of
sharing,
it.
sir, I'm sharing by my side. So,
No, it's okay, it's okay. Organizing team can move for the CROWN trial, please. Can move ahead the slide. Yeah, so are you able to see the CROWN trial slide
Yes.
on your screen now?
Yes, sir.
Yeah, so you continue with this slide. Okay.
Okay, so thank you, sir. So in this CROWN trial, they are randomized in 1:1 with the lorlatinib and crizotinib. Lorlatinib is given 100 mg per day, and crizotinib is 250 mg BD, and these trial is stratified by the presence of either brain mets are present or absent, and Asian versus non-Asian population. The primary endpoint of the CROWN is PFS by blinded independent central review committee, and the secondary endpoints are PFS by investigator, oral response rate, intracranial oral response rate, depth of response, intracranial time to progression, OS, and the safety profile. So the baseline characteristics are well balanced in the both arms, and about 44% of the population in both is Asian population, and about 94 to 95% patient have adenocarcinoma histology, and brain mets at the baseline are present in 26% of the lorlatinib arm. So when we look at the efficacy of CROWN trial, so the primary endpoint of the PFS by both the blinded central review committee and investigator, both are met in CROWN trial, and it's supported by the secondary endpoint of PFS by investigator assessment too. That is, at 12 months, 78% of the patient are progression-free with lorlatinib in compared to 39% with the crizotinib. When we look at the 5-year analysis of efficacy, so after 5 years of the follow-up, the median PFS with the lorlatinib has not been reached with an investigator-assessed PFS rate of 60%. So this PFS benefit, which exceeds 5 years, is the longest reported PFS in the advanced non-small cell carcinoma to date. That is, the PFS is not reached with the lorlatinib arm, and it's 9 months with the crizotinib with a hazard ratio of 0.19. So in patient with the both with baseline brain mets and without baseline brain mets, lorlatinib leads to improved PFS with the median PFS is not reached in the both arms. That is, in patients with the baseline brain mets are present, 53% patient are progression-free for CNS disease at 60 month, and 63% patient are CNS progression-free in patients without any baseline brain mets with lorlatinib. So the median PFS is not reached with the lorlatinib in crown and 9 months with the crizotinib with a hazard ratio of 0.19. And in Alex trial, when we look for the alectinib data, that is 34.8 month median PFS with alectinib and 11 months with the crizotinib with a hazard ratio of 0.43. So lorlatinib delays the intracranial progression in compared to crizotinib, and there is no intracranial progression is seen after 36 months. That is, at 2 years, 94% patients are progression free of intracranial disease. That remains consistent with the 92% at the 3 year, 4 year, and the 5 year also. 92% patients are intracranial progression free. So lorlatinib delays CNS progression in the both patients with existing brain mets and delays the onset of the CNS disease in patients without any baseline brain mets. So in patients with the baseline brain mets, lorlatinib leads to the higher intracranial response, and the majority of which are complete and durable response. That is, complete intracranial response is seen in the 58% with the lorlatinib in crown and 38% with the alectinib in Alex trial. So when we see the subgroup analysis in the median PFS in the poor prognostic group, that is a subgroup variant 3 is 60 month that shows the lorlatinib activity exists across all the variants of AML4 ALK fusion mutations. And the median PFS for variant 3 in Alex trial with alectinib is 17.7 month, lower than the lorlatinib. And also in patients with the P53 mutation, the median PFS with lorlatinib is 51.6 months. That shows lorlatinib have activity in difficult to treat population also. When we look at the resistant pattern, that after ALK TKIs, the resistant to second generation ALK TKI is mainly driven by the secondary ALK kinase domain mutations, particularly G1202R mutation. Lorlatinib is potent third generation LTKI that have activity against all resistant mutations, also against the ALK G1202R mutation that are frequent with the first and second generation LTKIs. So with the more sequencing of the first and second generation LTKI, using lorlatinib at the end, after using this, the more ALK resistant mutations are appeared. So lorlatinib suppresses the emergence of single ALK resistant mutations, and the upfront lorlatinib use can significantly delay or suppress the on-target resistance. So the resistant mechanism in lorlatinib used patients, there is no new single ALK mutation or ALK compound mutations are seen, but the resistance occur by the bypass mechanism like the MAP kinase pathway aberration or P13K mTOR pathways. When we look for the safety profile of lorlatinib, the adverse event that leads to the dose reduction in the crown study with the lorlatinib in 23% patients, and the adverse event that leads to treatment discontinuation is equal in both lorlatinib and crizotinib, that is 11%. So the most common grade 3 and grade 4 adverse event that are seen in the lorlatinib treated group are the hypertriglyceridemia, the most common, that is 25% patients having grade 3, grade 4, followed by the increase in weight, hypercholesteremia, and hypertension. The other
Dr.
side effect.
Sajda, can you just wrap it
Finish.
up?
Okay,
Yeah,
just
finish
that.
it fast because
Yes, sir.
yeah.
Other frequent side effects are edema, peripheral neuropathy, and cognitive effects. Majority of the CNS side effects are grade 1, 2, and these are cognitive mood effects and speech psychotic effects. So the safety profile is of lorlatinib is consistent with the primary analysis. Only 5% patients discontinue lorlatinib due to treatment-related adverse events. and dose reduction did not compromise systemic and intracranial efficacy. When we so for the lorlatinib adverse reaction management, first prepare the patient and caregiver about the side effects that may occur, monitor frequently with each visit, and manage with the symptomatic supportive therapies, and reassess at each visit. So for the management of the hyperlipidemia, lipid-lowering agents like the pravastatin or rosuvastatin can be used. If the elevated levels occur, then that is cholesterol more than 500 mg per dl and triglyceride up to 1000 mg per dl, start these lipid-lowering therapies or change these therapies. And when life-threatening elevated lipid levels, that is cholesterol more than 500 mg per dl that occur, then stop the lorlatinib, hold lorlatinib, and start change these lipid lowering therapies. And when cholesterol level falls to less than 400 mg per dl and triglyceride comes down to less than 500 mg, then restart the lorlatinib. And if it further worsen, then further decrease the lorlatinib by 25 mg. With the peripheral neuropathy and CNS side effects also, hold the lorlatinib and add the symptomatic supportive therapy and do dose reduction.
Sanjana, please finish the
Ji, sir.
presentation.
So about 50% patient, 50% of the side effect are resolves with the one dose reduction, and with 71% side effects resolve with the dose reduction without any impairment of the overall CNS PFS and without impacting the PFS. There is an Indian study about first line use of lorlatinib of Dr. Ullas Batra sir that also consistent with the lorlatinib safety and effectiveness with the overall response rate of 74%. So I'm concluding this with the lorlatinib offers more than 5-year PFS in first-line ALK-positive non-small cell lung carcinoma with the longest PFS ever reported in the advanced lung cancer. So 60% of the patients are progression-free with a hazard ratio of 0.19 and 92% of the patients remains protected from CNS progression. So lorlatinib is now the new standard of the care in first-line setting. Thank you. Thank you, sir.
Thank you, Sajna. I think everything has been covered. So no question, please. And we move to the next session. That is again the EGFR positive cases. This is going to be presented by Dr. Prashant Kumbhaj, Senior Consultant Medical Oncologist, Narayana Hospital, Jaipur. And he is likely to present a tale of two stories. Means redefining the treatment of outcome with Marisopa 2 and Papillon trial. Dr. Prashant Kumbhaj.
Good evening, Pawan
And
Agrawal sir, and good evening,
this
Somani sir.
this session is a sponsor session and is going to sponsoring by Johnson and Johnson company. Yes, Prashant, please.
So good evening, Pawan sir and Somani sir, and thank you, Pulkit, for inviting me as a speaker for
Thank you,
this
sir, for
session.
joining. Thank you. Thank
So
you.
please share the slides. Please share the slides. So in next 15 minutes, we'll be discussing about role of amivantamab with chemotherapy in EGFR mutated post-osimertinib progression as well as a first line in exon 20 mutation. Next slide, please. Yeah. So if we see the current outcome of advanced NLCLC, there is a room of improvement because real world 5-year OS rate is around 18%, and nearly all patients experience disease progression and ultimately die of lung cancer because of resistance to the treatment. And this is important because avoidance or delay of acquired resistance has the potential to improve, to maximize duration of treatment, improved median PFS as well as improved median OS. Next slide. So most patients treated with first-line EGFR TKI develop progressive disease due to acquired resistance. Whether if we give first, second generation, median PFS is 9 to 15 months. And if we give third generation, the median PFS is 19. Next slide. And as per recommendation, osimertinib is the current standard first line. And if we see the median PFS, it is 18.9 months, and intracranial median PFS 15.2 months, and median OS is 38.6 months. So although OC is effective in this patient group, tumors eventually become resistant and disease progression happens. Next slide. And if we see the pattern of acquired resistance, so we can see the on target as well as off target mutation. So on target EGFR mutation, off target MET amplification, MAP PI3K pathway. And if we see this graph, so here we can see this MET amplification, which is the mutation which comes earliest in this patient population, followed by EGFR C797X. Next slide. And if we see the resistance pattern in osimertinib alone or whether we combine osimertinib with chemo, so mutation pattern is the same, but slightly more mutation if we see the osimertinib compared to chemo with osimertinib. And there is no novel mutation found. Next slide. And if we see this slide, there different strategies has been given to overcome the resistance to osimertinib, whether we can opt for fourth generation TKI, EGFR TKI, or whether we can opt for off-target inhibition with combination of VEGF, PD-1 antibody with chemotherapy, or combination of off and on-target inhibition like EGFR with MET inhibition like amivantamab with chemotherapy, or other target antigens which we can target like HER3 ADC, MET ADC, TROP2 ADC. Next slide. So platinum-based chemo is the current standard of care upon progression of osimertinib, and if we see the overall response, it is 27%, median PFS 5.5 months, median was 14.7 months. Next slide. So as we have seen the pattern of resistance, so we need a different agent which can tackle all these resistance as well as give benefit and improve progression-free survival. So amivantamab, that is a dual antibody that addresses several problems of resistance in common EGFR mutation in advanced NSCLC, like it tackles EGFR binding as well as MET binding, and it has immunological mechanism of action for tumor reduction. And it also reduces the crosstalk between EGFR and MET by binding both targets. And this molecule has a better penetration of intracranial mets, which we'll see in trials. Next slide. So overcoming resistance constitute a major unmet need. So whenever a patient progresses, we should do NGS testing to identify which mutation is there. And real world studies have shown that chemotherapy demonstrate a median PFS of 4.7 months. Next slide. So this is Mariposa 2, which has been presented in ESMO 2023 in Madrid. Mariposa 2 phase 3 global randomized controlled trial, amivantamab with chemotherapy versus chemotherapy in EGFR mutated advanced NSCLC after progression on osimertinib. Next slide. So this is the design of the study. Patient with locally advanced metastatic documented EGFR exon 19 or 21 mutation positive progressed after osimertinib monotherapy. Stable brain mets were allowed. Radiation definite therapy was not required. And stratification factor OC first line versus second line Asian race, yes or no, history of brain mets. So 3 arm was chosen. And patient one randomized as to 2:2:1 ratio, AMI with lazertinib with chemotherapy, chemo alone or AMI with chemotherapy. So here we'll discuss only chemo alone with AMI chemotherapy. And dual primary endpoint of PFS by independent review committee as per RECIST. And secondary endpoints, overall response, duration of response, OS, intracranial PFS. Next slide. So Mariposa 2 is like Mariposa 1, and it is a unique RCT, and that required brain imaging all the patient. Next slide. And if we see the demographic and baseline disease characters, these are well balanced between both the arms. So brain mets plus or no, yes or no, all equivalent in both the arms. If we see the mutation type, EGFR mutation type, both are baseline characters are equal. Next slide. So significant number of patients had a brain mets at the baseline. Next slide. And if we see this Kaplan-Meier curve, so it shows significant 52% reduction in the risk of progression or death versus platinum-based chemotherapy alone. And if we see the median PFS, it is 6.3 versus 4.2 months with a very good hazard ratio of 0.48. And if we see this is the independent review committee assessed PFS. And if we see the PFS by investigator, it is 8.2 versus 4.2 months. Next slide. And if we see this forest plot, so this shows consistent PFS benefit of MA with chemo across all the subgroups, whether patient had a history of brain mets or not, first line or second line osimertinib therapy, EGFR mutation type. So this is better across all the subgroups. Next slide. So all subgroup favored ACP and consistent results indicate that no single subgroup drove the overall result. Next slide. And if we see the PFS among Asian patients, and it shows 46% reduction in the risk of progression or death by 46%. And this is consistent with overall population. And if we see the median PFS, it is 6.8 months versus 4.2 months in Asian patient population. Next slide.
Sir, sorry to interrupt you. Please conclude your session in next
Sorry?
1 minute. Sir, please conclude your session in next 1 minute, please.
Yeah. So efficacy is consistent among Asian patient population with similar PFS over the overall population. Next slide, please. Next slide. And if we see the overall response, it is almost double. And if we see the intracranial PFS, again, we can see the 45% reduction in intracranial progression or death compared to chemotherapy in ITT population. Next slide. And here we can see the early separation and sustained CNS protection gives benefit of this amivantamab with chemotherapy in intracranial PFS. Next slide. And it shows significant improved PFS intracranially. Next slide. And if we see the intracranial PFS with history of brain mets and no prior radiation, so median PFS is not reached versus 6.3 months in chemo. Next slide. Next. So by omitting with brain radiotherapy, we are able to better isolate intracranial activity attributed by amivantamab. Next slide. And this combination has demonstrated a favorable trend toward overall survival benefit versus platinum-based chemotherapy. And here we can see
Prashant sir, we are not able to hear you.
Sir, I think his screen is frozen.
I think is he left?
Yes, sir. उनका network, I think network issue.
We'll just wait for a minute if he'll join back again. Just wait for a minute. Dr. Prashant is joining back in a minute. Just give him a minute. Is he showing online?
सर इसमें तो अभी नहीं ज्वाइन किया उन्होंने.
I think he's just give him a minute. He's trying again. क्या हुआ सर? कर रहे हो क्या ज्वाइन?
Sir, we are already late. Can we conclude?
Okay. Can someone call Dr. Prashant and tell him that we can move forward? Can someone from the organizing team call him, please?
Sir, okay, I am calling.
Yeah, yeah. Just call him once so that he can at least read the concluding slide. I think we can move ahead forward. I think we can move ahead forward.
Sir,
Yeah.
okay, now we invite Dr. Pulkit Nag. He is consultant in medical oncology, Apex Hospital, Jaipur. Sir, it's a sir, over to you, sir.
Yeah, yeah. Thank you so much. Thank you so much, organizing team. And I think we are running a little late, so I'll try to finish it off as soon as possible. The session is sponsored by Dr. Reddy. I hope my slides are visible.
Yes, sir.
Are they
Yes.
visible? Yeah, okay, fine. So I'm going to discuss about immunotherapy in advanced esophageal squamous cell carcinoma, moving beyond PDL1 as a gatekeeper. My video is on now, I hope. I'll just switch on my video.
No, sir.
Yeah,
No,
yeah,
sir.
yeah. I'll switch it on.
Now you are visible.
Okay. And my slides are full screen. All right. Okay. So immunotherapy in advanced esophageal squamous cell carcinoma, moving beyond PDL1 as a gatekeeper. So why, like toripalimab, the first immunotherapy launched by any Indian pharma company, the molecule details it is an humanized IgG4 monoclonal antibody, is administered as an intravenous infusion, and each vial contains 240 mg, the fixed dose. So we can see the diagram of PD1 and see the glycosylation independent binding of toripalimab to FG loop of PD1 And toripalimab binding affinity with PDMM remains similar irrespective of PD-1 glycosylation status. So I think that is the upper part of toripalimab. Also, it has a higher affinity than pembro and nivo. There's a slower dissociation than pembrolizumab and nivolumab after binding to PD-1. In respective to T cell activation, toripalimab shows significantly higher average fold change in interferon gamma secretion compared to pembrolizumab. Toripalimab demonstrates heightened potency in activating CD8 T cells even without PD-L1 expressing antigen presenting cells or tumor cells. So if you can see like in which country and in which uh, like in which indication it has approved. So in United States, it is approved in first line and second line recurrent metastatic nasopharyngeal cancer. For China, it is approved in melanoma and lot of other status. When it comes to India, it is mostly approved in first line and second line recurrent metastatic nasopharyngeal cancer. Whereas in another EMA countries and 27 countries of EU and UK, even it is approved in first line esophageal squamous cell carcinoma. So this is the clinical trial layout of toripalimab, and we have seen the approved countries in where it is being approved in the post-operative, adjuvant, and perioperative settings, like in gastric cancer, hepatocellular carcinoma, non-small cell lung, in consolidation in small cell lung cancer, and in the first line we have in NSCLC, TNBC, SCLC, RCC, urothelial cancer, nasopharyngeal cancer, esophageal squamous cell carcinoma, and also in hepatocellular carcinoma. So if we talk about the global health problem, we all know that esophageal cancer is the 11th most cancer worldwide, 7th most common cause of cancer death, and 500,000 new cases per year. So we all know that incidence of esophageal squamous cell carcinoma is falling in many developed countries, and adenocarcinoma incidence is increasing in the developing countries. I think the relationship is to the food habits, which is being changed quite significantly. So if we talk about the mortality and prevalence, the new cases are around 70,000. And if we talk about it is the fifth most common and fifth leading cause of cancer death in India. So an epidemiological analysis and study of time trends over last 20 years. So in Indian demographic, if you see the age is, it is also been seen in 25 and also in 89, but the median age is around 54 to 55 years. The location is B2 esophagus is the most common, and the same thing we see in a clinical practice, and also the lower esophagus. So it is 41% versus 37%. The squamous cell carcinoma was the most common histologic type with in almost 80% of the patient. I think mostly it is related to the high incidence of smoking. So if we talk about the difference in the risk factor, if we talk about tobacco, mostly in squamous cell carcinoma, adenocarcinoma increased risk also related to smoking, with dietary factors with low fruit intake, low vegetables, high alcohol, and high intake of meat leading to increased risk of squamous. And with similarly for adenocarcinoma, with infectious agent, we have HPV-16 for squamous and H. pylori infection at high risk for adenocarcinoma, and hot beverages for tea and like for squamous cell carcinoma. And if we talk about GERD and Barrett's esophagus, it is mostly related to adenocarcinoma. So I think if we talk about the diagnosis and management, the MDT is a key to success, and endoscopy mostly useful in early or late tumors and do biopsy lymph nodes. So most useful in early or late tumors, scan and biopsy and do the biopsy of lymph nodes, and less useful in diffuse and mucinous gastric cancer. Also, we do laparoscopy with or without washing in locally advanced T3, T4 adenocarcinoma of G junction, infiltrating the anatomical cardia and gastric cancer to rule out the peritoneal metastasis, that is 15%. And in patients who are candidate for surgery, and assessment of medical fitness is recommended. Nutrition assessment and early intervention may improve the outcome. So, squamous cell carcinoma has TPS more than 1% in case of first-line treatment with nivolumab and nivo-ipi, and PD-L1 positivity is defined as CPS greater than 10 in case of first-line treatment with pembrolizumab. With gastroesophageal adenocarcinoma, HER2 overexpression, PD-L1 overexpression, CPS more than 1 or between 5 or greater than 10, MSI high, deficient MMR, and claudin 18.2. So these are all the molecular pathology and the predictors for squamous cell carcinoma as well as adenocarcinoma. So advanced and metastatic esophageal cancer, we have ESMO updated guidelines. With PD-L1 positive, if we see, then in more than CPS 10, we give pembro plus chemo. In PD-L1 TPS more than 1%, we have nivolumab plus chemo or nivo-ipi. And PD-L1 TAP score more than 5%, we have now also have tislelizumab with chemo. And also in second line, irinotecan and taxane. If PD-L1 is unknown, then we can use platinum or fluoropyrimidine-based chemo, and also tislelizumab and nivolumab also has a data on it. So treatment decide based on PD-L1 positivity levels. So the first line study in advanced esophageal squamous cell carcinoma, keynote 590. If we see that in median OS is 12.6 versus 9.8, and PFS is 6.3 versus 5.8 in all patients, and with PDL1 positive, it is in more than 10, it is 13.9 versus 8 OS, and PFS is 7.5 versus 5.5. And in Checkmate 648, it is also shown that if it's PDL1 TPS more than 1%, then response is higher as compared to in all patients of esophageal squamous cell carcinoma. So now what about toripalimab plus chemotherapy in treatment naive advanced esophageal squamous cell carcinoma? We will talk about Jupiter 6 trial. So it is the age is 18 to 75, locally advanced recurrent metastatic squamous cell who has not received the treatment, relapsed more than 6 months for non-metastatic disease after the last neoadjuvant, no prior use of immunotherapy with a good eco performance status. So we have compared toripalimab 240 mg with chemotherapy paclitaxel in comparison with placebo plus chemo, and then see what the results are. These are the median baseline characteristics and profile of the patient, and most of them are CPS more than 1, that is around 78% of the patients. So there is a 42% reduction in risk of progression or death in the arm of toripalimab plus chemotherapy, with the median PFS of 5.7 in intention to treat population. With PDL1 expression subgroup in CPS more than 1, it is 5.7 versus 5.5. And in CPS less than 1 also, it is 5.7 versus 5.6. So not a major difference. This is the forest plot showing in which all the cases toripalimab is better. So we can see even in PDL1 less than 1 also, the benefit is seen with toripalimab plus chemotherapy. So the post-hoc analysis of Jupiter 6 study according to PDL1 subgroup has shown in PDL1 more than 1%. We can see the difference of toripalimab plus chemo versus chemo, and in PDL1 less than 1% also, the response is being maintained. So this is the efficacy of overall survival. With the 42% reduction of that, we can see the clear separation of the curve, and the difference is 17 versus 11 months. And when PDL1 expression with CPS more than 1, it is 15.2 versus 10.9. And in CPS less than 1, it is not reach versus 11.6 months. This is again the forest plot showing in all benefits toripalimab is better. The post-hoc analysis of PDL1 TPS subgroup with PDL1 more than 1%, the response is 16.9 versus 10.8, and in PDL1 less than 1%, it is not evident versus 11.6 months. So I think in both these cases, the response in OS of toripalimab plus chemo has been maintained. To sustain long-term survival benefit of addition of toripalimab to chemo, the updated OS data. So 3-year OS data is 29.7% versus 19.9%. And the median OS is 17.7 versus 12.2 with a significant p-value of 0.002. The survival outcome with toripalimab versus placebo in combination with chemotherapy in patient with high versus low PDL1 expression status. So obviously, higher the expression, the response is better, but also in PDL1 less than 1, the response is being maintained with toripalimab plus chemo. So we have been seen, if we look at the response around the complete response was seen in 30% versus 18 in the placebo plus chemo, and overall response rate is 69.3% versus 52.1%. This is the safety results. I think most of the side effects were tolerable, and there was no major grade 3 side effects in view of which we have to worry something. So conclusion, toripalimab offers statistically significant and clinically meaningful OS benefits in patients with advanced or metastatic esophageal squamous cell carcinoma. The addition of tori plus paclitaxel as a first line provided superior PFS and OS benefit, and the survival benefits were significantly greater in toripalimab versus placebo arm, regardless of PD-L1 status. It's the next generation PD-1 inhibitor demonstrated superior efficacy versus chemotherapy in metastatic esophageal squamous cell carcinoma. So I think we have discussed all the points of summary that regardless of PD-L1 CPS, toripalimab plus chemo was associated with significant PS and OS, even maintained in the post hoc analysis. And these pool results further supported the superiority of tori plus chemo versus chemo alone, regardless of PD-L1 status, in recurrent and metastatic esophageal squamous cell carcinoma. So this is the table showing the comparative analysis. And if we look at the toripalimab data, the response is pretty much maintained. And I think the upper edge is that irrespective of the PD-L1 status in any of the patient, we can add de novo tori plus chemo. So thank you so much for your kind attention. Yeah.
Thank you, sir.
Yeah.
Now
So
I
I think
welcome.
yes, please,
जी
please
sir.
go ahead.
नहीं sir, please आप बोलिए.
Yeah, so I think thank you to organizing team and thank you Dr. Subhash for waiting for extra time. So kind of you. Dr. Subhash is a dear colleague of mine and I welcome you Dr. Subhash for presenting the another session. Organizing team, please take care. Thank you.
Thank you, boss, to having me here.
And Dr. Subhash Chanberva, he is consultant medical oncology, JNU Hospital, Jaipur. Over to you, sir. This session is sponsored by ENTAS. जी sir.
Slide, please. Thank you, Pulkit sir and organizing team. Today I will speak on the next generation IU and what's the difference. Next slide. So as we all know that pembrolizumab and nivolumab get the accelerated approval in 2021, but it was withdrawn due to failed in the follow-up results. Next slide. So now this satralizumab is the first PD-1 inhibitor which is approved in for the extensive stage small cell lung cancer, and it is approved in European Medical Association in Europe and UK, and it also get approval in India. And the S10005 trial shows that the satralizumab shows a significant OS benefit in the extensive stage small cell lung cancer, which is a 3 times higher survival rates at 4 years versus chemo, with a hazard rates of 0.06. Next slide, please. So, in compared to the atezolizumab, durvalumab, tislerli, and toripalimab, the satralizumab has the highest ESMO MCP scale, which is the hazard ratio with 0.6 and the gain of more than 3 months in OS. So, as in the IMpower 133 and the CASPEN trial, we know that the atezo and the durvalumab had the 3 months of OS benefit, but the which designated at the MCP score 3, but satralizumab had the score 4, which has a substantial OS benefit. Next slide. So we know that extensive small cell lung cancer has a very aggressive disease, that it has a rapid proliferation rate, high TMB, but it is a highly immunosuppressive microenvironment. And there is modest benefit with the PD-L1 agent like atezolizumab and durvalumab. So we need a stronger and deeper and more durable immune activation in this disease. Next slide. So satralizumab has the multiple characteristic in the molecular structure and the mechanism of action. That it has a large OP-type region which occupy around 5% of the binding site between PD-1 and the PD-L1. and it has a low immunogenicity that avoids the overreactive immune response, and it has a high affinity to the PD1 receptor that occupy more than 90% of receptor. It also improves the T cell activity by enhancing the PDL1 endocytosis. It improves the T cell activity by reducing the recruitment of CD28 cells, and it has a robust anti-tumor activity by promoting proliferation and activation of the affected T cells. Next slide. So it has saculumab has a significant superior PD1 interaction compared to pembrolizumab and the nivolumab. And this chart we can see that at the 6 hours the PD1 endocytosis peaked by pembrolizumab and nivolumab mediated endocytosis was relatively weaker. Second, we see that the preservation of the CD21 mediated signaling restore the T cell function better than the pembrolizumab. So saculumab block the co-clustering of CD28 with the PDL1 during the T cell activation better than the pembrolizumab. Next slide. So the saculumab is a novel anti-PDL1 monoclonal antibody which designated the IgG subclass 4, and its structure is consistent with the heavy chain, variable chain, and the variable light chain. But it has the higher binding capacity, which is 10 times more to nivolumab and 3 times more to pembrolizumab. Next slide. In contrast to pembrolizumab, saculumab binds to the same epitope but approaches PD1 at a different angle because its chains contribute differently. So the structural and spatial analysis, it more complete binding and blockage than the PD1 inhibitors. Next slide. And during the immune modulation, it also protects the T cell by minimizing the Fc-mediated cytotoxicity. As it antibody-dependent cellular cytotoxicity, it causes the weaker Fc gamma binding, which leads to natural cells not activated, and it prevents the T cell killing. By CDC protection, it poorly binds to the C1 complement 1Q binding that do not trigger the complement cascade that also prevent the T cell lysis. And another is the antibody-dependent cellular phagocytosis. Due to weaker Fc interaction, macrophages do not get engulf the T cells. That also leads to the preserve the T cell population. So more functional T cells are there. There is a more stronger immune response than the superior anti-tumor effect with a good safety. Next slide. So saculumab it has a higher affinity than other PDL1 inhibitors, 3 times more affinity to pembro and 10 times more affinity to nivo, and it occupies more than 90% receptor PD1 receptor, and it robustly induces the PD1 receptor endocytosis, resulting in the reduction of the PDL1 receptor retained on the surface of T cells. Then it sustains activation of the T cell by preservation of the CD28 mediated signal restore T cell function better than the PD1 receptor inhibitors. And this strong modulation on the tumor microenvironment, it mobilizing immune cell to turn the tumor to cold tumor into hot. And we all know that the small cell is a cold tumor, immune cold tumor. Next slide. So a more complete immune activation resulting from dual PDL1 to PDL2 pathway. As we know, the saculumab is a PD1 inhibitor, and the blockade of PD1 on the T cell prevents the interaction between PDL1 and L2 on the surface of tumor cells. The anti-PDL1 agent interact with the PDL1 and only partially blocks this pathway. And additionally, blockade may elicit a more intense T cell activation, hence a stronger anti-tumor response compared to the other PDL1 agents. Next slide. So we know that the saculumab has a higher receptor occupancy and the durable PDL1 blockage and the more PDL1 internalization leading to the prolonged T cell activation and the CD28 acceleration, which cause the enhanced tumor cell killing. Next slide. So And we understand that the serplulimab has a unique mechanism of action, including PD-1 binding affinity, the PD-1 receptor endocytosis, and the preservation of the CD28 signaling, potentially explaining its enhancing T cell activation. And it is the world's first PD-1 monoclonal antibody approved in the extensive stage small cell lung cancer. It has the highest ESMO MCB scale, scoring 4, which indicating the substantial clinical benefit more than Pembro, Atezolizumab and Nivo. And there are head-to-head trials are ongoing comparing to atezolizumab, and in phase 3 limited stage small cell lung cancer will further add the evidence of serplulimab in the various lung cancer setting. And it is the world's first and only PD-1 monoclonal antibody which positive results from a phase 3 registrational trials in the perioperative treatment of gastric cancer. Next slide. Thank you.
Thank you, Dr. Subhash, for a wonderful presentation. And again, thank you for joining so late and having the patience for it. Thank you. Thank you. Thank you. Dr. Deepak, I need 5 minutes of Dr. Prashant Kumbhat, sir. Just 2 minutes. His presentation, two
नहीं
slides
सर
were
अभी
left.
नहीं नहीं सर डॉक्टर दीपक का ही है नेक्स्ट सेशन
Okay, thank you,
बात
thank
हो
you.
गई
Dr. Deepak. So, Dr. Deepak is a very dear colleague of mine, and currently he is working as a consultant and head of the department in very prestigious Indian Railway Hospital. And I welcome Dr. Deepak to the dais, and all is yours, Dr. Deepak. Thank you so much. Thank you.
Thank you, Dr. Pulkit sir, for giving me this opportunity. And good evening, respected Dr. Somani sir and Dr. Pawan sir, my mentors. Although it's a very exhaustive topic, but I will try to stick to the time, and already we are very late. So
Thank you,
just
Dr. Deepak.
start. So my screen is visible to everyone.
Yes, it's visible, Dr. Deepak. It's visible.
Okay. Thank you, sir. So I will be discussing few points about extending benefits in EGFR mutated NSCLC, the power of combinations. So as we all know that Asian population is having more EGFR mutations, like almost 40% in comparison to non-Asian population. And in those Asian population, our Indian patients are having almost 33 to 39% of EGFR mutation. So EGFR mutations are located in tyrosine kinase domain and result in increased kinase activity of the EGFR, leading to continued cell proliferation. This is the mechanism of action. If we talk about the timeline of the development of EGFR targeted therapy, the first EGFR targeted therapy was gefitinib, which was developed in 2003. And since then, we have moved ahead with osimertinib for T790M mutation in 2015. And now we have osimertinib with combinations and further so many newer molecules like sunjovertinib and osimertinib consolidation therapies in 23 and 24. So if we talk about survival outcomes with EGFR tyrosine kinase inhibitors, earlier with all the EGFR molecules, only PFS advantage was there. No OS benefit was there, but with osimertinib, there is OS advantage. So this is the only TKI which is having OS advantage. Then why we need the combinations? If we see the group of patients, very few patients remain on therapy after 2 years, and there is need to further improve outcomes in EGFR mutated patients. And very few patients have very good 5-year OS rate, highlighting the heterogeneity of the disease. In the table, there is the patient who are receiving osimertinib as first line. Their retention rate of the receiving of the second line therapy is only 28%. For osimertinib, it is 28% at 36 months, while in first generation TKI cases, it is only 9%. If we see the combination therapy EGFR TKI, so the first few trials were NEJ 009 and TMH study. It showed that gefitinib, when combined with chemotherapy in treatment naive patients, there was definite PFS advantage, and that was 20.9 versus 11.2 months with single agent, and the hazard ratio was only 0.49. Similar results were there in TMH study also. So they have shown that TKI can improve outcomes in addition to with addition to chemotherapy. So what are the key questions in selecting the treatment? We have to look for efficacy, we have to see the safety, and the patient selection is the foremost important thing. There, the current standard of care is of osimertinib. As we can see, there are few patients who are early progressors and few patients who are very few long-term responders. But in each and every case, at present, current standard of care is osimertinib. Then there are three important trials. We see that Flora 2, and that Mariposa. And if we compare all the three trials, there is the Flora is having a HR is 0.8. Then with combination of chemotherapy, it is 0.7, and with in Mariposa, it was around 0.75. So is there still a role for single agent osimertinib? For whom should all patients be considered for combination? So to select these patients, this is very good table. As we can see, then in EGFR L858R and deletion 19 mutations, which are very commonest mutation. So Flora 2, that is osimertinib, is having very good results. With brain met patients, again osimertinib is better choice, and with liver mets, the Mariposa, that is amivantamab, is better choice. But in co-mutation, TP53 co-mutation positive patients, again osimertinib is a good choice. And if patient is having baseline ctDNA positive, and then again the osimertinib is good choice. So in all the subgroup of the patient, osimertinib is the first choice in comparison to amivantamab. If we talk about Flora 2, which is combination of chemotherapy with osimertinib, the PFS benefit was seen in all the subgroups. Similarly, OS benefit was seen in all the subgroups except some non-Asian patients. There was no OS benefit seen. So if we see the final analysis, the median OS was 37.6 months in OSI monoarm. With OSI with chemotherapy, it was 47.5 months. While in Mariposa, it was 36.7 months for osimertinib, and while in amivantamab and lazertinib arm, it is not evaluated or not reached. If we see the data maturity, the maturity of the data was more in Flora 2, that is 57%, while in Mariposa, it was only 45%. Then if we compare with the 3-year and 4-year, the overall survival analysis, it is much better with osimertinib. If patient is having TP53 co-mutation, whether it is prognostic or predictive, in both the trials, prognostic TP53 co-mutation was there, but it was predictive only in Mariposa 2. And we have seen that osimertinib again is better performing in TP53 mutated patients. This was on paper. The top study was presented in ELCC 2026. So according to this top study, if we use osimertinib with chemotherapy in TP53 co-mutated patient, there is definite advantage in PFS. It is more with osimertinib with chemotherapy. And in monotherapy arm also, it was good. If we see the OS, again, OS advantage was also there. So the conclusion is that top study prospectively demonstrated that osimertinib plus chemotherapy significantly improved PFS in patients with EGFR mutated advanced NSCLC patient with an PFS advantage of 34 months. If now the monitoring and post-progression therapies, how to monitor the patients who are on TKI. So in Flora, they did CT at every 6 week of interval for first 18 months, then every 3 months after that. Brain imaging was done only in patients who are having suspected brain mets or symptomatic brain mets. Then in Flora 2, CT scan baseline, at baseline it was done, then at 6 weeks and 12 weeks thereafter. Brain scans to the progression. In Mariposa, they did MRI and CT every 8 weeks. So every 2 months, MRI and CT image. Subsequent therapy, only 65% of the patients received subsequent therapy in Flora. And then in Flora 2, it was 77%. In Mariposa, it was 76%. Crossover was not allowed in Mariposa trial. If we talk about the toxicity, the most common toxicity was diarrhea among all three drugs or all three combinations, rash and paronychia. So these three were specific, class side effects of EGFR mutants. Then how to optimize the supportive care, and does dose density matters? Yes, definitely. Toxicity was typically worse in initial 4 months, and initial chemotherapy can forestall resistance. So osimertinib should be combined with chemotherapy, and it can delay the resistance development to the osimertinib. If we see the heterogeneous mechanism of the acquired resistance, first is
Sorry to interrupt you. So
yeah.
kindly concentrate in 1 minute.
Yeah.
Deepak, conclude kar de.
Okay. Just within few minutes. So there were so many heterogeneous mechanisms for acquired resistance. One is EGFR, that tyrosine kinase domain mutation. Another mutations in MET and HER2, and then there may be histologic transformation is small cell lung carcinoma. There are some unknown mutations also. So what are the future directions in EGFR mutated NSCLC? At present, if we discuss about MET-driven resistance, this is an unmet needs. We don't have any specific drug, but now there is savolitinib, which is a selective MET inhibitor to overcome MET-driven resistance. It acts on the intracellular domain of MET, and it inhibits the signaling pathway. Then there are certain ADCs. We know the effect, bystander effect, immune modulatory and targeted therapy effects. The first important ADC is TROP2 directed. There are three important things: DXD, then secukinumab govitecan, and secukinumab tirumotecan. Then HER3, there is new molecule patritumab deruxtecan, which can be used. Trials are undergoing. And after target treatment are exhausted in all actionable genetic alteration patients, there is no standard of care. So a substantial mix in treatment options can be found in later treatment line of treatments. Then there are some Asian expert perspective. We can see what our Asian experts think. Almost 54% of the patients, 54% of the expert believe to use combination therapy in first line. If we talk about the comparison between Flora2 and Mariposa, the first and foremost important thing is safety and tolerability, which is more with osimertinib. Included in NSCLC, so osimertinib is a preferred option. Then this is the summary we have already discussed. Then we can use targeted therapy. We have to understand the resistance mechanism. Combination studies are better, and emerging therapies like ADC for TROP2 are the newer molecules. Thank you.
Thank you, Dr. Deepak. Thank you, sir. Now I invite Dr. Pulkit Nag, sir, for the next presentation.
I'll share my slide. And before that, Deepak, thank you so much for taking out time in the night, so late night. And it was a wonderful crisp presentation by you. So hoping to see you more in the future. Thank you, brother. Thank you so much. So I'll share my slides. Are my slides visible?
Yes, sir. Yes, sir. Visible.
Okay. So we're going to discuss evolving trends in the management of HER2 positive metastatic breast cancer. With the outline of the presentation, we're going to discuss HER2 positive MBC, the unmet need in second line positive HER2 positive MBC, recent advances in HER2 positive MBC, current treatment algorithm, and what the take home message is. So we all know that approximately 30% of the breast cancer cases will become metastatic after diagnosis, and around HER2 positive breast cancer cells are associated with aggressive disease that is more likely to metastasize. And 15 to 20% of the invasive breast cancer cases are HER2 positive, that is IHC3 plus or IHC2 plus with HER2 gene fish positive. So TNBC is 13.3, hormone positive, HER2 negative is 65, and 20.7% are HER2 positive, in which 13% is hormone plus HER2 positive. So few discoveries have shaken the foundation of cancer treatment, like discovery of HER2 oncogene. HER2 overexpression confers an aggressive tumor behavior. So what are the unmet need for HER2 positive MBC? More than one third of the patient will not receive subsequent therapy after second line treatment and may miss an opportunity to receive highly effective HER2. So patient is de novo metastatic, 78% will receive second line, and around only 65% will receive the third line therapy. So if we talk about the two important key data trial, that is Cleopatra and Amelia. In first line, we have THP, and in second line, we have TDM1. And we can see the benefit of Cleopatra trial of around 6.3 month benefit in PFS and 16.3 in OS. And in second line TDM1, we have a benefit of 3.2 in PFS and 5.8 month in OS with their respectable drug-related side effects. So the median PFS drops by approximately half, moving from first line treatment with THP to second line treatment with TDM1. So median PFS dropped numerically by half if we move from THP to second line TDM1 from 18.5 to 12.4. And if we look at TDM1 in second line, so it is 18.5 if we use in the first line THP and drop by around 50%, 9.6 months by using TDM1 in second line. So Cleopatra and Amelia were conducted simultaneously 2012, and now there are real world evidence studies also supporting the use of them second line TDM1 following pertuzumab. So evidence suggests that PFS outcomes for second line TDM1 are worse in patients who receive prior pertuzumab. So if the patient has received prior pertuzumab and then if they have received the TDM1, the response is not so good. So what is the basic mechanism for it? It is because due to reduced HER2 expression, the DM1 has a limited permeability and is unlikely to impact tumor cells beyond HER2 positive. Further supporting the impact of HER2 expression on TDM1 effectiveness are data from post-hoc analysis of marine study. So because of this mechanism, if the patient has received pertuzumab previously and has progressed, then the effect of TDM1 is pretty less. So what are the recent advances in HER2 positive MBC? There are 8 anti-HER2 drugs that is approved: trastuzumab deruxtecan, TKIs like niratinib and tucatinib, margetuximab till 2020. Now we'll talk about TDXD, that is trastuzumab deruxtecan. The mechanism of action, we all know it has a high potent TP topoisomerase 1 inhibitor payload. It has a cleavable linker and it has a 8 raised to 1 drug to antibody ratio. So the TDXD demonstrated response to therapy in 60.9% pretreated patient population with HER2 positive MBC. So I think it's a great data because once the disease progresses in HER2 positive, very few drugs respond. As far as mechanism of action is concerned, we know it first binds to HER2, then it is internalized, then there is a cleavage of linker releasing topoisomerase 1 inhibitor, then topoisomerase 1 inhibitor enters the nucleus and there is a tumor cell death. Also, it has a bystander effect on the neighboring tumor cell because of the membrane permeable payload, which helps in the bystander effect. So, was the Destiny randomized phase 3 open label multicentric study in which HER2 positive metastatic. So TDXD was compared with trastuzumab or capecitabine or lapatinib plus capecitabine with a dose of 5.4 mg per kg, and we can clearly see the separation of the curve with the response of 42.2% versus 13.9% with TDXD, and with key secondary endpoint of OFS around 39.2 versus 25 was the difference, and 69.3% of the patient who discontinued treatment. So conclusion is in Destiny Breast, TDXD demonstrated statistically significantly meaningful improvement in PFS and OS versus chemotherapy for HER2 positive MBC, and there were new safety signals were identified, and it confirms Destiny Breast 02 that favorable breast benefit 1. With 03, we have de novo metastatic patient who has been treated previously with trastuzumab and taxane, and we could have clinical stable brain mets. So brain mets were included in this study, and it is a direct comparison of TDXD with TDM1. Most of them were Asian patients, and the brain mets were included at the baseline. This was the approximately 60% of the patient each arm received prior pertuzumab, and even after that, the PFS was strongly of TDXD with TDM1, and 32.2% patient treated with TDM1, 58% had progressive disease, and 32% patient TDXD had progressive disease. So the 12-month progression-free survival rate difference was 75.8 versus 34.1. This was the forest plot showing the PFS in the key subgroup, and I think in all the subgroup, TDXD was the dominator arm. With PFS with blinded independent central review, the difference was 28.8 versus 6.8 point. It is quite a significant difference with a very significant p-value. And similarly was maintained with OS of it was not reached with TDXD. And in comparison, we can see the clear separation of the curve of TDXD over TDM1. With OS, the benefit is 52.6, what is 42.7 months, and it is being maintained up to 4 to 5 years. Sensitivity analysis for OS in ESCO 0 to 4. The sensitivity analysis represent the OS data would have been observed if TDXD treatment post-trial had not been administered. This is the same PFS KM curves for patient with or without brain mets. So whether patient had the brain mets and not had the brain mets, TDXD has shown superiority over the TDM1. The overall safety summary, we have seen that rates of grade 3 were similar between TDXD and TDM1. With TDXD, mostly it is pneumonitis in 5.8%, and with TDM1, we all know that thrombocytopenia, pneumonitis, and thrombocytopenia were the major side effects. It's highly emetogenic, and that's why when we give in our clinics, we do give quite a good antiemetic measure before giving TDXD. This we have already discussed. So this slide shows that can TDXD be rechallenged after grade 1 ILD. So 33% patient who received treated with TDXD experienced ILD2, and the median time to ILD2 onset from TDXD was 64 days. Around 75% of the patients who were treated with steroids for ILD2 recovered or recovered with sequel. So conclusion is the analysis demonstrated promising potential for reinitiation of TDXD treatment following the management and full recovery of grade 1 in the, ILD. This approach will optimize clinical outcomes and maximum the therapeutic benefit of patient. So if there is grade 1 ILD with TDXD and we have properly managed and patient is fully recovered, we can reinitiate the treatment. So even the quality of life as measured by EORTC QLQ C30, the quality of life was maintained and there was no mean change from the baseline. So conclusion, TDXD demonstrate clinically meaningful and statistically significant improvement in OS over TDM1 with the maintained PFS benefit. Median PFS for TDXD was 4 times longer than TDM1. Around 78% patient experienced the ORR, and the OS's benefit was maintained across all the key specified subgroup. We could talk about tucatinib, which is a HER2 climb trial, HER2 positive MBC prior treatment with trans-2, PER2 and TDM1. The brain mets were included. So we have compared tucatinib plus trans-2 plus capecitabine versus placebo plus trans-2 plus capecitabine. And we can clearly see the ORR is 41 versus 23%. Median PFS is 7.8 versus 4.9, and OS is 21.9 versus 17.4. So in without brain mass and with brain mass, in both this condition it is maintained, and especially in brain mass, HER2 climb has shown a greater efficacy because of its crossing ability of blood-brain barrier. So higher objective response rate with tucatinib, and the diarrhea was the most common adverse effect, and the other is the various TKI side effects which we see, like we see hand-foot syndrome, diarrhea, and hepatotoxicity. Niratinib plus capecitabine, that is NALA trial, versus lapatinib plus capecitabine in HER2 positive MBC post 2 lines of therapy. If we compare, the response was maintained, but the PFS was 8.8 versus 6.6 and 24 months versus 22.2 months. We all know the classical side effects of TKI. So what is the current treatment algorithm for HER2 positive MBC? First line option is PER2 plus trans2 plus DOSI, THP, then, or PER2 plus trans2 plus PECLI. Second line is most dominant is TDXD. Now we are also having trials in which we can move TDXD to the first line. And third line we have tucatinib plus trastuzumab, TDXD, niratinib, and we have upcoming drug called margetuximab plus chemotherapy. And this is the NCCN guideline. In consensus, we can see that in second line, TDXD holds a strong position. So between first line THP and second line TDM1, PFS drops numerically by half by the use of TDXD. And the current treatment paradigm for HER2 positive includes THP followed by TDXD after progression in second line. And then we have in third line tucatinib, niratinib, TDM1, and margetuximab. So thank you so much, organizing team.
Thank you so much, sir, for taking this session.
Yeah.
And sir, again, it's over to you for the conclusion.
Yeah. Yeah, so I think
of
it
today's
was
session.
I think thank you to the organizing team for managing it well. And I would like to thank all the consultant and all the respected participants who have participated today. And I think we are charged up for the tomorrow session. And thank you so much. And I think it's a way out. And good night to everyone. Thank you so much once again.
Good night, sir. Good night, everyone.
Thank you. Thank you.
Hello.
Tech team, we can wind up the session.
Okay, ma'am.
Okay, just a second. Let me click a screenshot. Yeah, okay now. Thank you.
Thank you.